Hello everyone.
Hello ma'am.
Hello.
Yes, namaskara.
Namaste, thank you.
Dr. Mahapatra, Dr. Bharti.
Madam, good
Hello,
evening.
namaste. Good evening.
Namaste.
Braj.
Good evening,
Everybody, Sangeeta, good evening.
Ma'am, good evening.
No, I
Namaste,
think
ma'am.
all of them, they have joined, but I think you have to call Suchitra
Come, ma'am,
and
has to join,
Raj.
ma'am.
Yeah.
Are you calling?
The ma'am told she'll join any minute.
Okay, fine.
I'll call again, I'll come on. Ma'am? Hello, ma'am. Yeah, yes, ma'am, please. Please, waiting all of them away.
What happened?
Yeah, now she'll join, ma'am.
Yeah.
Number was busy, now she just picked up. She said she'll join in.
Yes, Alka ji joined. So, welcome, madam.
Yeah.
Vidya madam, namaskara.
Namaskar, namaskar.
Rachnava, Brijbala madam, ಸ್ವಲ್ಪ ಬೇಗ ಹೋಗ್ಬೇಕು. Hold, she'll be there for a short while. 5 p.m.
Yeah.
she'll have.
Okay.
Hi Alka, how are you?
All my friends.
I'm
So nice to see you. Hi, Vidya. You are
Hi.
looking so good.
Namaste, namaste, madam.
Namaste. Welcome to KSOGA. Namaste.
Hi Janmajay.
Hi, Janmajay. How are you?
Hari.
ये क्या मार्केट है क्या? Namaste, sir. We thank all of you for joining our Gyaan Sangam program. And I think now, Rachna, you can start the program.
Yes, ma'am. A very pleasant evening to all here. Today's webinar is KSOGA-Gyaan Sangam, which was started in 2023 during the tenure of our beloved past president, Vidya Tobi ma'am. So every fortnight we have this program on a Wednesday evening. The aim of this program is that we all join together, share the knowledge, and we involve all the Foxy members from all over India. So without much delay, we'll start today's program with a prayer. Arun? Thank you, Arun. So, I request Bharti ma'am to welcome all who have gathered here. And before that, I would like to introduce our president, Bharti ma'am. Bharti ma'am is our present president of KSOGA. She is the consultant at Sahyadri Multi-Speciality Hospital, which was Bharti Nursing Home at Hassan. She's been the KPME state president, state vice president. She's been the director at Hassan Indian Red Cross Society. Madam has organized many conferences, and she's been the IMA state past vice president, IMA Women Doctors Wing EC member. She has held all the posts at Hassan Society. She has received the President Medal as topper in final MBBS in Madras University. She's the Foxy President Rotating Trophy as Secretary of Hassan. And she's received the Dr. D.K. Tank Award twice as Hassan Secretary. And she's been the recipient of a rotating trophy as President of Hassan and recipient of Rajotsava Award for work in healthcare in Hassan. And she has many interests in non-communicable diseases and adolescent health, high-risk pregnancy, preventive oncology, and geriatric health in women. Ma'am, I welcome you. I request you to welcome the
And thank you,
gathering.
Rachna, for that elaborate introduction. Namaste, and I extend my pranams to all the senior faculty from Foxy over here. So at the outset, this Gyaan Sangam program has been going on since the past 1 year, and it is indeed a privilege to have so many Foxians who have held eminent posts and served the Foxy Association as well as the society. So at the outset, I would like to extend my heartfelt welcome to Dr. Alka Kriplani Madam, who has been the past president of Foxy, and Madam is a well-known, eminent academician, and we welcome you, Madam, to our KSOGA-Gyaan Sangam program. And the other person, we have many more eminent persons with her. We have Dr. Suchitra Pandit, who all of you know. Madam has been also the ex-president of the Foxy, and at the moment she is the representative of Foxy to Suffolk. Dr. Suchitra Pandit, ma'am, we welcome you to this KSOGA-Gyaan Sangam. Dr. Janmajaya Mahapatra sir, who is the Vice President of Foxy. Sir, we extend a warm welcome to you on behalf of all the custodians from our association. And then we have the chairpersons who we have invited, Dr. Jyoti Banglawala. She has just sent me a message that her father is in hospital and she will be unable to join us. We wish her father a speedy recovery and hope to interact with Madam in the next coming sessions. And we also extend a warm welcome to Dr. Asha Bakshi, who has been the past vice president, and she also has said that she'll be joining in a little late. And probably on behalf of all the custodians, we extend a warm welcome to you, Madam. We extend a warm welcome to Dr. Arpita Singh from Diogar. Madam is the president of this Diogar very young society, and she has agreed, in spite of her busy schedule, to grace the occasion. We welcome Dr. Arpita, ma'am. Then we have our own office bearers who and all the participants who will be participating in this very interesting session of our Gyaan Sangam, which usually takes faculty from all over the country. That's the north, south, east and west zone. And we have Dr. Shivanand, who is a dermatologist from Tumkur. We welcome you, sir, for having agreed to come and talk to us about the common dermatological problems in obstetrics and gynec practice. And I also extend a warm welcome to the moderator of our panel, Dr. Jyotika Desai, a very senior member of our KSOGA, and she has been very active even in the Foxy and ever ready to conduct any academic program. We welcome you, Dr. Jyotika. We welcome our President-elect, Dr. Durgadas Astrana, our immediate past President, Dr. Vidya Tobi, my Secretary of KSOGA for this year, Dr. Rajeshri Paladi, and the Treasurer, Dr. Suman Gaddi, and all my dear KSOGians. I'm not taking names for everybody, all of them, and with the blessings of our Chief Patron, Dr. M.G. Hiremat, and our Patron, Dr. Nagraj, who are a little busy today. They may not be able to join the session. I declare this Gyaan Sangam program open, and I hand over the session to Dr. Rachna, who will be convening and coordinating the program. Thank you.
Yeah, thank you, ma'am, for that warm welcome. I request our today's program director, Vidya Topi ma'am, who is contesting for the vice president post of Foxy for the year 2024. Ma'am, I request you to speak a few words, ma'am.
Thank you, Rachna, and thank you, Dr. Bharati, taking further this Gyaan Sangam ahead. And I again welcome all our dignitaries on this dais. My dear Dr. Alka Kriplani, Dr. Suchitra Pandit, as well as Dr. Janmajay Mahapatra. And I must tell that KSOGA is growing. So we have 20 societies and 2 more societies are forming. And academic sessions are going on. We have also 20 these one committees, and we exchange programs amongst us also. And this Gyan Sangam actually aims at various topics and exchanging the academic opinions and views across India. So I really thank everyone who have joined, and let us find out something new from this webinar. I thank again KSOGA platform, as well as those who are watching this across through Karnataka as well as the other states. Thank you very much, Rachana. And
Thank you,
welcome.
ma'am. Thank you,
Thank
Vidya
you.
ma'am, for guiding us. So now I request our ever smiling Secretary ma'am, Dr. Rajashri ma'am, to introduce the chief guest of today's program, Alka ma'am.
Pranamams and good evening to everybody. Hearty welcome to this program, and it's a proud privilege to have Dr. Alka Kriplani ma'am as the chief guest for this evening, who has taken time out of her busy schedule to be present here and grace the occasion on KSOGA. Dr. Alka Kriplani is no stranger to anybody on the country or in the land of India. We have known her as a very, very progressive academician, as a clinician par excellence, and who continues to do her clinical work of excellence even now. My privilege and honor to introduce Dr. Alka Kriplani ma'am, whom I have been associated for the past 15 years or so. I've seen her from very close quarters. Madam is the chairperson for the Department of Obstetrics and Gynecology and Artificial Reproductive ART Center, Paras Hospital, Gurugram, ex-professor and HOD of Obs and Gynae. We all know what Alka Kriplani means in AIMS, and her professional associations have been, ma'am, I need to introduce you because the youngsters who are there on the platform should know what doyens we had in our field of obstetrics. And madam has been the president of FOXI, president of Gynecological Endocrinological Society of India, president of Delhi Gynecological Endoscopic Society, president of Association of Obs and Gynae Delhi, editor of the Asian Journal of Obs and Gynae, and on editorial board of 9 journals, 47 awards, Padma Shri Award. What more can I say? Dr. B.C. Roy Award, Honorary FRCOG. Ma'am, let me also read this because I also need to know what are the credentials here. IMA Meda Achievers Award, then Rashtriya Gaurav Award, Vidya Vibhushan Award, CNBC Award, FIGO Award, Economic Times Award, and about 1,000 lectures, 73 orations, and live workshops, about 156, publications 417, organized conferences, workshops to the tune of more than 140. Ma'am, how is it all possible?
Great.
And we are so very happy to have you on this platform.
Yes.
Thank you so much, Archana, for your lovely, kind words. I am here, and my dear friend Vidya Thobi, I'm a big admirer of Vidya. When Vidya was young, she's still young, but I have very old association with Vidya. From Gulbarga, we used to know Vidya is a big boss there, doing all academic activities. One of two my residents have worked with her, and they have such high, praises for you, Vidya. I wish you all the best,
Thank you. Thank you very much.
And Dr. Bharti, the president of the society, I think I'm meeting her for the first time. Such a lovely lady. And she did her introduction part with so much of excellence and perfection. And what to say, your society down south, so much of academic work is going on. Especially the topics of this webinar are too good. We keep on talking about high-risk pregnancy, PIH, gestational diabetes. These two topics are great. I was telling my staff, these dermatological problems in pregnancy, for small little things, we keep on getting derma consultations. So it's a very, very pertinent topic. And second, DEXA. Even I will be interested knowing what is the recent in DEXA. And because we gynecologists, we just keep shunting them to orthos. So these are very good topics. We keep on talking the daily routine, what we do. But what our colleagues, we keep sending patients, we should have basic knowledge. So our consultations are less and we can counsel patient more carefully. So I congratulate you people for such an excellent choice. And at the end, I would say, Vidya, wish you all the best.
Thank
And
you.
you
Thank you
know,
very much.
and you know, we may not meet often, but you are very, very dear to my heart. You are such a
Thank you
genuine
very
one,
much.
dear.
And to tell you, Madam, our Bharati Rashekar is also contesting for chairperson perinatology committee. So do bless her.
Bharti,
And I
very
wish
nice.
that from the north, maximum votes should come to her.
Sure, sure. Bharti, wish you all the best. All the
Yes.
best.
Yes.
So you make a team with Vidya, huh?
Yes.
Thank you.
Yes.
Your pronouns, your blessings mean a lot to us, madam. You
Yeah.
are,
Thank you.
your
Actually, we ladies, we half of the life because of children, we don't go out. So
Yes.
you people are doing such good work, but people may not know us as they should know us. So
Yes.
it's a very nice initiative you both have taken. Wish you all the best.
Yes. Thank you. Thank you very
Okay, and
much.
thank you for the invitation. Thank you.
Yeah, yeah. Thank you very much, madam.
Okay, bye bye.
Thank you.
Thank you, ma'am. Thank you, ma'am, for the inspiring words. Now I request Rajeshri ma'am to introduce Suchitra Pandit ma'am and Janmajaya sir.
Thank you so much for the privilege given, Rachna. It's my privilege to introduce Janmajaya Mahapatra sir, who is been a senior consultant in the Department of Ops and Gynae and Postgraduate Institute of Cancer in Cuttack, Odisha. He's held various organizational positions, the Vice President of FOXI the year 2024 now, Treasurer of AGOI 2022 to 24, Treasurer of AICOG 2018, Chairperson of the Clinical Research Committee FOXI 2013 to 15, Joint Secretary FOXI 2011, Chairman YGOG Committee of Association of Gynec Oncologists of India, and Chairperson of the Preventive Oncology and Public Awareness Committee AGOI continuing, Treasurer of the Association of Gynecological Oncologists of India, Joint Organizing Secretary for Bhubaneswar 2002 Conference, Organizing Secretary of the Vaginal Surgeons of India at Bhubaneswar 2018, Treasurer of SOVSI 2018, even continuing now, Organizing Secretary of the Purvam 2017, Vice Dean, IMA College of General Practitioners, and National Joint Secretary of the IMA College of Joint Practitioners, Honorary State Secretary, IMA Odisha, National Chairman, IMA Standing Committee for Medical Education for 2013 to 15, and life member of IMA FOXI, AGOI, IMS, IAG, ISAR, ISPAT, ISOPAB. When many national awards, IMA National Awards for Best Dedication to IMA for all the GCP activities in the year 2022, IMA National Award for Best State Secretary, IMA 2016 to 17, and IMA Special Award for organizing 221st Working Committee meeting held at Puri, and various publications in FOXI and Gynec Oncology journals, and field of special interest is gynecology.
Thank you.
Please,
Thank
yes, sir, welcome to the gathering.
Thank you, Dr. S.C. For respected Chief Guest, Dr. Alka Kripalani Madam, Guest of Honor, Dr. Suchitra Pandit Madam, Past President FOXI, and Chief Patron KSOGA, Dr. Hiramat, Patron Dr. Nagaraj, President Dr. Bharati, President-elect Dr. Asrana, President, Past President Dr. Vidya Thobi Madam, Honorary Secretary Dr. Rajeshri, Treasurer Dr. Suman, Speakers and Chairpersons of the webinar, panel moderators, Dr. Jatikan, Chairpersons of the panel, Dr. Arpita and Dr. Asabakshi, and all the veteran panelists, senior faculty, my dear fellow delegates and my dear friends. First of all, I am congratulating Dr. Bharati, President KSOGA, and all the office bearers of KSOGA for organizing this beautiful webinar on the topic KSOGA-Gyaan Sangam. The topics are Dexascan, when and why, and skin disorders and pregnancy, and panel on GDM, which will surely benefit our members in their day-to-day practice. I welcome all the delegates to this very important and informative webinar organized by KSOGA and on wellness of women. We'll learn a lot from this webinar, which will help us to change our practice and ultimately translate to good clinical practice. Thank you again, Dr. Bharati, and all the
Thank you very much, sir, for being
Peace bearers and members of KSOGA, to Vidya Madam for VP election and Dr. Bharati for chairperson election. Thank you all. Long live Fakshi.
Thank you,
Thank you,
sir.
sir.
Thank you.
Arun, please share Suchitra Madam's CV. Rajeshri ma'am, please do the
Yes,
needful.
Good evening, everybody, again. It's my honor to be introducing the very sweet past Foxy president we have, who is a FIGO Women's Awardee for the year 2018, Dr. Suchitra N. Pandit, Senior Consultant in the Department of OBGYN at Surya Group of Hospitals, Mumbai, Foxy Representative to SUFOG 2024 to 26, Associate Member of FIGO Ethics Committee for the year 2023 to 25, Chairperson of AICC RCOG 2017 to 20, President ISOPAP 2018 to 20, President Justices Association of India 2016 to 21, President of Foxy and ICOG in the year 2014, President Mumbai Society of OBGYN 2013-14, Professor and Unit Chief of LTMMC and LTMG Hospital Sion, PG teacher for 39 years, conducted several research projects, including International Team Breach Trial Project, examiner for MBBS, and initiated the Foxy Justices Hypertensive Disorders in Pregnancy Certificate, conceptualized the Foxy Youth Mela for empowering the youth, done more than 300 CMEs and 8 guidelines in 2014, continuing work on GCPR, Secretary of the Foxy UNICEF Sion Kishori Adolescent Empowerment Project at Dharavi for 8 years, member of the APAI Committee, winner of the Lord of Planets Award, UK 2019, FIGO Women's Award 2018, Maharashtra Medical Council Award 2016, Honorary Fellowship of Nepal Society, Mox Dr. Desai Award for Excellence, and Mox Dr. Patki Award for Think Global and Be Local, Foxy Korean Award, awarded 44 orations, more than 2,500 guest lectures in India and abroad, 124 publications, authored 5 popular books, Caesarean Birth, Fibroids, MCQs, Pelvic Organ Prolapse, and Manual for OBGYN Practice. Hearty welcome to you to this August gathering, ma'am. And it's a pleasure and very inspiring to know we have such giants in the field of OBGYN who keep continuing and inspiring with their good work.
Thank you very much. Once again, the KSOGA group, we recently all met when Vidya Topi had invited me to Gulbarga. And well, Vidya has done a fantastic tenure, and I'm sure Bharti will also extend a very, very good program for the entire year, along with her very capable team of all the KSOGians. And Alka is a good friend. I know Janmajay for many, many years. It's lovely to see everybody on the same platform. And good, I'm also impressed with the different varieties of topics that you all have been taking up. And DEXA scan, of course, is important. The skin lesions, I would suggest mammography in your future things. And of course, GDM is a burning topic because diabetes in pregnancy is so very common. So you've chosen your topics very widely. But what I'd like to say is, Bharti, I'm very, very keen to now see you at the helm of affairs as the chairperson of the committee that you have chosen, I think perinatology committee. So all the best for that, because I think there are people now with experience who are all ready to take on the chairperson's post. And so also, Vidya, we are looking forward to your installation as vice president from the South Zone. And I'm sure, once the South Zone comes alive, we have all the zones from India coming alive, and that's where the Foxy will improve. And finally, our women's health, will be our topmost priority, and our MMR rates will come down even further. I'd also like to say that all the KSOGians, please exercise your voting rights. Many a times we like our candidates, we support our candidates verbally, but when it comes to voting, we shy away from voting. So please do not forget to vote. Even if Vidya may come in unopposed, Bharti will need support from all the chairpersons and the presidents and secretaries of all the societies. So people, my dear friends, do not forget to vote. And once again, all the best for today's program. And lovely to see all of you, and hope to keep in touch with each and every person. Thank you very much.
Thank you, Dr.
Thank
Thank you,
you.
Sujitra ma'am.
And for that excellent word thing that is said, please exercise your vote. That is your might. Your vote is your right and your might. Thank you very much, madam, for the wishes and the good words.
All the best.
Thank you.
Thank you,
Thank you, Suchitra. Thank you. Thank you very much.
So now, with all the inspiring words from the seniors, we move on to the scientific session. We have the first talk, which was supposed to be chaired by Dr. Jyoti Banglowala, but she had to leave due to unavoidable circumstances. So I request Bharti ma'am to give a talk.
So we thank all the for blessing us and having us on. As I said, as a very less spoken topic, what we would say, what we but this we come across almost every day in our clinical scenarios. We are seeing this. So I will be sharing my slide now. My slides. Just give me a minute. So I will be now talking about the DEXA. So when I first said DEXA to Rachna, Rachna said, Madam, we are talking about dexamethasone, when and why? Because she said, Madam,
Yes.
people are still using betamethasone, and I think we should speak about that. Yes, one webinar definitely will talk about which is better, dexamethasone or betamethasone in preterm labor. But today I will be talking about a very less spoken topic, as I already told you, that is the DEXA. So this DEXA is the DEXA scan that I'm talking about, because we have to always think about even our women in the midlife, who all of us, I think all of you will know that in every clinical day of clinical practice, there is not a single day gone when somebody does not come and tell you that I have severe backache, or they will tell you that if you're posted for surgery, they will say, I don't want spinal anesthesia because the spinal anesthesia is going to cause me backache. So these are the common scenarios we come across, but we all need to understand that this problem of backache in our women is not just due to menopause, it is also due to altered lifestyle habits, modifications which are occurring, and I think we need to talk about them and ask them to protect their bones. And the KSOGA theme for the year is promote wellness and prevent illness. So that was why we thought of talking about the bone health. So we all know that bone health, we have the healthy bones, we have the osteoporotic bones. I mean, the osteopenia should be here, and once the osteopenia has reduced, increases, we will see that they come to us with severe osteoporosis, and most often when they come to us, it is already, they come with a broken bone, and you know the morbidity and mortality associated with a fall in midlife or in menopause. So what the osteoporosis is estimated to affect 200 million people worldwide, and 82% of the bone specialists believe it is a silent epidemic. I'm sure that is very, all of you will agree on that. So 24% feel we have the healthcare system, but we have to support osteoporotic patients, and 90% have agreed that the condition should be a public health priority, just like the non-communicable diseases we are talking about. There is an enormous burden worldwide, as high as 1 in 3 women, especially I would say even in the Asian population and the Indian population, 1 in 3 women are at a risk for fractures, and 1 in 5 men are at a risk. And globally, we see about 8.9 million fractures annually, and most of them are due to osteoporosis. And globally, there is one fracture every 3 seconds, and the incidence is slowly rising. Years from 1990, it is projected by 2050, we will have more than 310% of mortality, morbidity of fractures due to osteoporosis. So what did the WHO define osteoporosis in 1994? WHO defined osteoporosis as a progressive systemic skeletal disease characterized by low bone mass and microarchitectural deterioration of the bone tissue with a consequent increase in bone fragility and susceptibility to fractures. So they have very clearly mentioned that the susceptibility to fractures is very high. And since microarchitectural deterioration could not be measured clinically, the operational description was based on a bone mineral density, giving a T-score which is scored above plus or minus 2.5. So by doing this bone mineral density and the T-score, we could prevent these fragile fractures and the morbidity associated with that. So all of you know that osteoporosis is a skeletal disorder characterized by reduction in bone mass. The low back ache is highly prevalent and affects their quality of life. I think this is what we come across in all our clinical practice, not just orthopedic clinical practice. And fracture is the clinical manifestation of osteoporosis, usually occurring at the spine, hip, and forearm. And the incidence is bimodal, which peaks in the young and then again in the very old people. And there is no gender inequality. Of course, the females have a higher incidence than males, but males are also prone to osteoporotic fractures. These are various studies which have been conducted in India where they show that the low BMD in many places is almost 45, in some studies going up to 55, and almost hovering around about 25% of them are suffering from osteopenia, and then about 12 to 30% are suffering from osteoporosis. So this is the incidence which not only globally but even in India, the fracture per year risk is increasing because of osteoporosis. So it has been reported that 61 million people in India have osteoporosis, and out of these 80% are women. And this is weighing a lot on our economic resources as well as healthcare resources. And we also know that 3 out of 4 people in India suffer from lactose intolerance, and they also have deficient calcium in their diet, which also increases the osteoporotic risk. So how do we assess the osteoporotic risk and prevent fractures? Well, that could be by doing the bone mineral density test. So it is a standard for measuring the diagnosis of osteoporosis and the fracture risk assessment. You're all familiar with the fracture risk assessment tool, or the FRAX, which is a chart which uses clinical risk factors, excluding the measure of BMD, and then we have a risk for osteoporosis or fractures. So this was implemented in 2008 by the WHO and is used to calculate the chance of a fracture in a 10-year time frame. So generally the FRAX chart will be like that, and then you have the age, you have the height, weight, and then the family history, the medical history. Are they on any glucocorticoids, or do they suffer from any skeletal muscle disorders? And depending on that, yes, no, we give them and then we take their BMD, bone mineral density score. Is it less than 2.5, or it is 1 or plus 2.5? And then we calculate the risk, and then we give them the 10-year probability of a fracture risk, saying that you may have this 9% or 19% or 20% risk of the fracture in the coming 10 years. So this is only a scale to give them the risk. So what are its pitfalls? It is not validated for use with total hip or lumbar spine, and it is not validated for the ethnic minorities. It is not of any use for those receiving treatment already for osteoporosis. It is not to be used for ages outside 40 to 90 years. And it does not include the history of fall as a risk factor, and it does not recommend whom to treat. It just gives you a risk assessment. So how do we give them a better outlook? So how would we tell our patients that they need to take care of their bones better? So for that, now we have this DEXA scan. So what is this DEXA? DEXA scan is useful for diagnosing as well as for monitoring the therapy of osteoporosis. It will show whether she is improving with that particular medication we are using for osteopenia or osteoporosis. It also gives us the assessment of the fracture risk. It also assesses the body composition. That is, it gives us the estimate of the fat and the lean mass assessment. So that helps the physiotherapist or the dietitian to speak to them about lifestyle modifications, and we can monitor the effects of treatment and whether our interventions are working. And it can also detect osteoporosis due to other conditions like hyperparathyroidism, osteomalacia, and certain cancers that may cause bone loss. So it is called the dual energy X-ray absorptiometry. That is the DEXA expansion, dual X-ray absorptiometry. It uses a very small dose of ionizing radiation to produce pictures of the inside of the body, especially the lumbar spine and hips, to measure bone loss. It is simple, quick, and non-invasive, and it is the most commonly used method for diagnosing osteoporosis. So this is how the image of a DEXA scan will look. It will give you the body symmetry, whether there is any shortening of any limbs. It will give you the assessment of the fat. It will give you the lean muscle mass, as well as it will give you the bone mineral content. So it is going to assess the body as a whole. So the DEXA is most often performed on the lower spine and hips, not the long bones or the ankle, like is done in the bone mineral density by the other tests which are done. And in children and some adults, sometimes the whole body may be scanned. And it is now the gold standard for measuring bone mineral density. And of course, DEXA is not always advised for children, but those children who are at a risk for osteoporosis or fractures because they receive glucocorticoid therapy or they are on radiation or chemotherapy for malignancy, they have certain endocrine disorders like Cushing's or hyperparathyroidism or hyperthyroidism, individuals with bone dysplasias like osteogenesis imperfecta, and individuals who are taking certain medications like glucocorticoids or anti-epileptic drugs that could change their BMD. So this is the BMD table where the patient will be resting and they are scanned for a short minute of 5 to 7 minutes, and the report is a computerized algorithm which will give you what is the bone mineral risk assessment will be given along with the body mass lean mass and the fat index. So what is the indication for DEXA? It is basically advised that all women 65 years and older and men 70 years and older should be screened for asymptomatic osteoporosis. It should be a part of our protocol in this general health checkup that we do for all our men and women. Women younger than 65 years, of course, if they have a risk, especially if they have had an early hysterectomy with the ovaries removed, they have an estrogen deficiency, history of maternal hip fracture before 50, low body mass index, or a history of amenorrhea more than 1 year before the age of 42, you could do it earlier for them. And women younger than 65 years old or men younger than 60 years, if they are heavy smokers, if they have had a loss of height, if they have thoracic kyphosis, that could be an indication for DEXA. Along with that, we will do DEXA scan, as I already told you, for those who are on glucocorticoid therapy, who have had any fractures in a younger age group, or hypogonadal men, or those who are being surgically or therapeutically induced with castration because of any gonadal tumors, and those children, persons on anticonvulsants, androgen deprivation therapy, aromatase inhibitor therapy, which we do use a lot in our practice, and chronic heparin therapy also induces osteoporosis. And these are some of the endocrine disorders I already told you who need to have that who could have an altered BMD, and they would require a DEXA scanning. Eating disorders we see a lot in our younger population, prolonged immobilization, and of course malabsorption syndromes, vitamin D deficiency, endometriosis could also lead to an increased incidence of endometriosis. And those who have undergone bypass for bariatric surgeries, they also will be affected by osteoporosis. As to contraindications, there are no absolute contraindications to performing DEXA. However, in certain situations, if the person has recently undergone gastrointestinal contrast or radionuclides for imaging, you should postpone the procedure. Always make sure the individual is not pregnant. It is contraindicated in pregnancy. And if they have a severe degenerative change or fracture deformity in the measurement, that is in the spine, the hip, or the lumbar region, then you may not be able to do the scan properly because of they cannot lie down on the table properly. Any implants, hardwares, or devices, if they are coming in the measurement area, not if they have pacemakers, it is not a contraindication. And if the patient is extremely obese or they have their handicap that they cannot take the correct position and remain motionless, then probably the assessment may not be accurate. And extremes of high and low body mass index, again, because the accurate and precise positioning may not be available. So any condition that includes positioning may alter the BMD values. So how is it done? All the personnel you require is a DEXA machine, and you may require a nuclear or a radiologic technician under the supervision of a licensed physician. So it has a C-arm basically with an X-ray source, allowing for variable photon energy levels. There is a collimator to assess it, and there's a detector to get back the images, and then it is there's an associated computer software which will give you the reports in a computerized format. So there will be a scanning table, an X-ray tube, and a detector. The patient lies on the scanning table while the scanner passes two X-ray beams through the body. These beams have different energy levels, typically low and high. Then the scanner measures the amount of X-ray energy that is absorbed by the bones and soft tissues. The detector records the images which are sent then to a computer system and calculates the BMD. Then the results are displayed as a T-score which compares the patient's BMD to the average BMD of young adults of the same sex. So this is a very simple procedure. You just put them on the table and then you have the technician and the results will be available. And once you get the results, I will show you. So before you tell them, it is always better to have a pre-test counseling and a discussion with them. You need to tell them that they will have to lie on the back for 10 minutes. And you tell them that if they're more than 300 pounds, then they'll have to go for either a CT or an MRI, because some models do not give them the results when the BMI is very high. And then you also have to tell them that if they've taken any contrast medium in the last 2 weeks, we will have to postpone the procedure and of course rule out pregnancy. Calcium tablets should not be taken 24 hours before the examination because they could interfere with the scoring index. The patient should wear comfortable loose fitting clothes and any metal components should be removed in their fittings like zippers. And if a prior DEXA is done, try to compare the results. And then preferably for those who want to do a body composition study, please ask them to fast and take a low-fat diet the previous 12 hours or before the procedure. And again, confirm these findings on the day of the discussion and then go ahead. You can either ask them to wear their own garments or you could always ask them to change into hospital gowns, which would be more comfortable just wearing their underpants. So as I already told you, it's a painless procedure. No special preparations are required and two sites are routinely evaluated, that is the lumbar spine and the hip. So once they are lying down on the back above the X-ray generator, the legs are positioned on the padded box and images are taken of the spine here and the hip. So the photon energy is transmitted to the collimator and from the collimator, the detector sends it to the computer, and the T-score is the number of standard deviations, which I already told you, and the Z-score is the number of standard deviations above or below the mean of age match controls, and the other one is matched with gender as well as ethnicity. So once the scoring and the results are out, this is how your DEXA scan assessment will be interpreted. So he interprets the scan on a T-score and it is determined to evaluate the standard deviation from the reference population. So it is normally, if it is 1, -1 is normal. So if it is less than -1 or greater than -2.5, it is osteopenia. If it is less than or equal, more than equal to -2.5, it is osteoporosis. And if it is equal to -2.5 along with a fragility fracture, they come with a fragility fracture or a hairline fracture, then it is severe osteoporosis. So if your BMD is -1 and above, you stay safe that your risk of osteoporotic fractures are going to be less. Whereas if you are in -2 or just above -2.5, you have to start taking therapy and lifestyle modifications so that you can prevent fragility fractures and the morbidity associated with that. So the scoring will be either normal, it will be osteopenic or osteoporosis. That's how the report will be interpreted. And depending on that, the classification of the T-score, you see that when it is normal, the percentage loss of bone mineral is 0. Whereas when it is -2, they are osteopenic, almost 20% bone loss is there. Whereas when you go down to -2.5 and -3, the bone loss will be around 25 to 30%. And when it is more than 4, it's going to be severe osteoporosis. And these individuals are at a very high risk of fragility fractures as well as major fractures. So this is how the computerized report will be coming, and we will have to interpret and tell them that they have to take treatment depending on their on the inference we get from the DEXA scan. Well, very rarely we may require to do a CT scan. It is not always superior, but in certain situations, as I already told you, extremes of body height and weight, extensive degenerative disease that they cannot lie down, and severely obese women. In such cases, we may have to do a CT, MRI to DEXA. So how often do we do the DEXA scan? So the National Osteoporosis Foundation of America says BMD 1 or 2 years after initiation, that is when they're on treatment, and then every 2 years thereafter. But the North American Menopause Society states that repeated testing in untreated postmenopausal women is not recommended. So you can ideally do it from every 4 to 5 years would be the duration which you will have to give before you repeat the scan. So if the scan tests are normal, you can ask them to get it repeated after 5 years. So the advantages are the high accuracy, a shortened time, and the precision of the technique, and there are removal of the various errors in the other methods. However, this fracture risk that the DEXA scan gives you is not a magic fracture threshold, because there may be individuals who do have a normal DEXA scoring, but still due to various other reasons, they may have a fracture. So we cannot tell them that yes, your BMD is 0, don't worry, you will never have any fractures. So we have to be careful when we talk to them. And this was true whether the correlation was between the forearm BMD and the hip fracture risk or the hip BMD. So we always tell them that for each standard deviation decrease in BMD, the risk of fracture is increased approximately twofold. However, it could vary sometimes. So ideally, this algorithm would be helpful in clinical practice when women with clinical risk factors, as I already told you, and other clinical factors like diabetes, hypertension, obesity, family history of osteoporosis or fractures, you could ideally take the clinical FRAX scoring you could do. And if they fall under low risk, probably in low resource setting, you don't have the DEXA available, you could just do the FRAX scoring and tell them that you're at low risk, and then give them lifestyle modifications and calcium and vitamin D supplementation to prevent osteoporosis. However, if they fall under the intermediate category in the FRAX, you could ask them to get the DEXA scan. If the DEXA scan indices are high, consider treatment. If it is less, then you can always tell them lifestyle modifications. However, if somebody has already had a fragility fracture, please do the DEXA scan, consider treatment following the DEXA scan, and even after treatment, please continue doing the DEXA scan once in 2 to 3 years so you can assess whether your interventions and your therapy is helping her increase her bone mineral mass. So who is at risk? I already told you the treatment. Yes, we have to tell them to consume food rich in vitamin D and calcium very early in life, not at the age of 55 or 60. We have to start talking to them, I would say, at the age of 30 to the Indian population, though we say that we generally talk to them at the age of 40. I think we should start talking from adolescence. We have to see that their bone bank is very rich early on in life. Do weight bearing exercises, because every other person who comes to you will tell them, yes, I go for a walk every day, I go for a walk every day. That is not sufficient. They have to do resistant and weight bearing exercises. We have to either have charts or refer them to a physiotherapist who can tell them what is weight bearing exercises, combine them with moderate intensity aerobic exercises, and take vitamin D and calcium as prescribed by the doctor. And of course, prevention, as I already told you, avoid smoking, limit alcohol use, get some exposure, regular exercises, and lead a balanced, healthy life so that you don't land up with broken bones like this and then suffer for a long time, because you know the quality of life is going to be hampered, especially when you're a senior citizen. The quality of life is going to be very, very difficult once you have a fall. So to keep our bones healthy, let us eat well, let us do the right exercises at the right time so that our bones are strong, we are strong. So it is essential that we identify postmenopausal women at the risk of fracture, implement dietary measures, and of course the bisphosphonates and the raloxifene or teriparatide treatment will be given. I am not going to go into the treatment of, we have non-pharmacological and pharmacological management of osteoporosis. I am not going to go into the details of this because this is beyond the scope of what I am supposed to talk today. So I thank all the chief guest, Dr. Alka Kriplani madam, and the guest of honors, Dr. Janmajay sir, and Dr. Suchitra Pandit for gracing the occasion. My thanks to Dr. Jyoti Banglawala and Dr. Asha Bakshi and all the panel, all the faculty from other societies in India who have joined us. We always ask us to let us save our bones, because we've seen many of our own doctors who say, I just sprained my leg or I have a small hairline fracture. So let us save our bones before time runs out, and let us all take care not only of the bones of our women, but also our own bones also. I have an humble appeal. I am contesting for the Foxy Perinatology Committee. Elections will be in August. The nominations will open in the month of May, the first or second week of May. I request all of you to kindly nominate me from your societies. Thank you and namaste to all of you. Thank you for the patient hearing.
Thank you, Bharti ma'am, for that enlightening talk. I hope from now on, instead of just prescribing some analgesics and calcium supplements, we'll go a step ahead and start asking for DEXA scans, ma'am. I hope many of the juniors here will definitely do that.
Not
Thank you,
available
ma'am.
in most of the smaller towns. I think so we'll have to try to get something in place that it is available everywhere.
Yeah. Okay, ma'am. Thank you, ma'am. So now we move on to the next topic. The topic is skin disorders in pregnancy and gynecology by our own beloved Dr. Shivanand sir, is from my own hometown, Tumkur. I welcome you, sir. And it is indeed a privilege for me to read his CV. Arun, can you please share sir's CV? Shivanand sir is the professor and HOD of the Department of Dermatology at Sri Siddhartha Medical College. And sir, Arun?
Arun, can you please play the CV of Dr. Shivanand?
1 second.
Yes. Sir is the professor HOD at Dermatology, Sri Siddhartha Medical College, and he is the editor-in-chief of Research Journal of Medical and Allied Health Sciences. Is the reviewer of 2 journals, that is the Indian Journal of Clinical and Experimental Dermatology, which is a CDR, and Journal of Krishna Institute of Medical Sciences, University. He also has many publications. He has 3 international publications and 4 national publications. His topic of interest being dermatosurgery, clinical dermatology, trichology, dermatoscopy, and lasers. Sir, I welcome you, and please, you can give your talk, sir.
Nice introduction. At the outset, I would like to thank the members of KSOGA, Dr. Durgadas and Dr. Rachana Madam for giving this platform. With these few words, I would like to share my screen for today's presentation. And today's topic is pregnancy dermatosis, the common dermatosis which you usually see during our day-to-day practice. Yes. As we all know, pregnancy is a physiological condition. This is characterized by changes in alteration in the endocrinal, metabolic, and immunological changes. This results in multiple cutaneous changes. That's what we see, maybe both physiological or few times pathological. Skin changes may be physiological because of the hormone changes that is associated with the pregnancy per se. Like
the slides are not
Excuse me,
moving,
sir.
Can
you're on the first slide now, sir, what we are able to see.
My slides are changing on I think Arun can take over.
No, sir. We can't see.
Please click on the slide once again, on the slide, main slide, and describe.
Yes. Am I able to change the slides?
No, here we are not able
Stop
to.
sharing, sir. Stop sharing.
Stop sharing. Okay.
Make the PPT slideshow, sir, first.
Yes.
Now you
Change it to
can
slideshow.
share screen, sir.
I'm not getting the Zoom meeting platform.
Sir,
Yeah.
open the Zoom, sir.
Yes.
Share screen, sir.
Yes. Share. Okay. Am I now?
Yeah. Yes, sir. Slide 2.
Okay.
Yes, sir.
Is it moving now?
No, sir.
Yeah.
But you're
Slide
not
2.
on slideshow. You're not on slideshow.
Make it full screen.
Make it
Make it
full
full.
screen and put it onto slideshow, sir.
Sorry.
Actually, we did try even before the program. Yeah, now it is changing, sir.
Is it changing?
Yeah, it is changing, sir. You have
Yes,
to
sir.
put it.
At the bottom, you can click that slideshow, sir.
Okay. Now is it changing? I'm changing myself.
It is at
Not changing
Oh,
and
fifth.
morning slideshow.
It's at the 5th slide. It is stuck there. You change and see, sir.
Now it's a slideshow. I think
Yes,
now
sir.
Yeah,
Yes.
now yes,
Fine.
it is safe. Yes, sir.
Okay, fine. Okay. So as I mentioned, these are maybe the physiological changes during pregnancy, any hyperpigmentation, or it may get affected by pre-existing dermatosis like lichen planus, psoriasis, and few specific dermatosis in pregnancy, or just on examination, it might be few skin changes just as in coincidental dermatosis. A few can risk the fetal life and requires surveillance throughout the pregnancy. So dermatosis are distressing. Just a minute. Okay. So this only doesn't cause not only pruritus for the maternal pregnancy, it also causes risk for the fetus. That includes fetal distress, or few times even prematurity, termination of the pregnancy, and even the worst possible is even the stillbirth. So this requires early diagnosis and treatment of the dermatosis, which will reduce the morbidity and mortality of not only the pregnant female, it also reduces or minimizes the exposure of unnecessary treatment and exposure to the fetus. So these are the physiological changes in pregnancy that might be the hyperpigmentation, striatum gravidarum, molluscum fibrosa gravidarum, pruritus, vascular changes. Pigmentation is few times generalized, or few times it may be confined to linea nigra, colasma or melasma, secondary areola, and pigmentation are confined to the body axillary folds, body folds such as and areas of genitalia, perineum, inner thighs, and neck. And few times even the new scars which are formed get hyperpigmented. And the lesions such as freckles or lentigens becomes more darker, or few times the pigmentary demarcation lines becomes more exaggerated. Striatum gravidarum, nothing but the stretch mark becomes more evident, and simple such as in skin tags, what we call as commonly called as skin tags, that's molluscum fibrosum gravidarum, start appearing in the body folds areas. And next, pruritus, generalized pruritus, or vascular changes may include spider angioma, telangiectasia, gingival hyperplasia, or edema, granular gravidarum, hemangiomas, varicosity, flushing, which can be seen in fair individuals, cutaneous marmorata, and palmar erythemas. These are the physiological changes. Then coming to the changes in the appendages, we may concentrate in upper glands, which becomes more prominent, and improvement can be seen in the hidradenitis suppurativa conditions or FOX5 diseases. Eccrine glands, patient may complaints of excessive sweating called as an hyperhidrosis, or even a few times these eccrine glands get blocked and patient will land up in a condition called as malaria, general common conditions. And in sebaceous gland, the glands becomes more active and becomes hypertrophic. And common complaint especially in the pregnant females is the hair loss. That might be accounting because of the telogen effluvium, or even the androgenic alopecia may get worsened. Hirsutism per se may get worsened. And nail changes, there may be increased or accelerated growth of nails. Dystrophic nails can be seen, and Bu's lines can be seen. Pigmentary, as I already told, there may be generalized pigmentations. Body fold area can be involved, and the specific pigmentation areas includes genitalia, axillary area, recent scars, and areolas. Linear pigmentation, that's in linea nigra, can be seen. Melasma or colasma, are also called as mask of pregnancy, becomes more accentuated. And some pigmentary nevus becomes more darker in color. So this is the pigmentation. Almost all pregnant women develop this type of pigmentation. This is nothing but because of the estrogen and progesterone, which are melanocytic, stimulate more production of the melanosomes and increase density on the epidermal melanocytes. These upregulations of tyrosine by human placental lipids. Most common changes can be seen as which is linea alba, which is converted because of the pigmentation into linea nigra. Hyperpigmentation also occurs around the nipple, areola, and secondary areolas. Melasma, colasma, or the mask of pregnancy is almost seen in 75% of the pregnant women, which is more aesthetically important. So this is the photo showing the linea nigra. This is almost seen in 91.4% of the pregnant female, most commonly seen, and this is nothing but the hyperpigmented linear line extending from the pubic symphysis to the xiphoid process. Melasma is nothing but colasma or the mask of the pregnancy because of the hormonal variations. This is also seen in 75% of the pregnant female, and it is more important in aesthetic importance. We can give sunscreens or ask to avoid sun exposures or demineralizing creams which are safe in pregnancy. Coming to the changes in the hairs, hirsutism can worsen, thickening of the scalp hair can be seen, and most common is the postmortem telogen effluvium and worsening of the androgenic alopecia. And in nail changes, we can see something dirty, warty looking collections in the nail bed that is called in subungual hyperkeratosis, or even the destruction of the nail that is distal onycholysis, transverse growing, brittleness, because the nail becomes so brittle that it starts breaking by itself, and as already told, accelerated growth. So this is the photograph showing the hirsutism in pregnancy. This gets worsened, and one of the commonest is the telogen effluvium, that is the loss of hair because of the pregnancy per se. And this is what I told, that is like a dirty, warty looking collection below the nail plate. That is called as in subungual hyperkeratosis. And the nail become destroyed, leaving behind brittleness. Mucosal changes involves gingivitis, the marginal gingivitis or papillomatous hypertrophy of the gums, or the bluish discoloration of vagina because of the increased vascularity, that's a Jacquemus-Chadwick sign, and cervical softening, that's a Goodell's sign. Glands, as already told, there may be increased eccrine functions. So patient starts feeling something like more sweating in their palms and soles. So that is called as an hyperhidrosis, or malaria, that's an obstruction of the eccrine gland, especially during these summer times, and elevated thyroid activities with a resultant relative iodine deficiency. The increased sebaceous functions shows that a Montgomery tubercles, decreased apocrine functions. So this is what prominent Montgomery tubercles in pregnancy. You can see multiple papule type around the areolas or the nipple. This becomes more prominent. Vascular changes includes spider angiomas, palmar erythema, non-pitting edema, that is both puffiness of the face or the lower limbs or the upper limbs, varicosities, gingival hyperplasia or hyperemia, pyogenic granuloma, that's called as a granuloma gravidarum, or pregnancy epilepsy, hemorrhoids, hemangiomas, unilateral naviate telangiectasias. These are the vascular changes. This is the photograph showing the spider navy. Here you can appreciate a small papule type of lesion having a spider type of things around it. So this appears as a red lesion with branching extending from the center. This appears usually in the 2nd to 5th month of the pregnancies, and this is also called as vascular spiders or the spider angiomas, arterial spiders or spider navy. So this is usually seen in the upper part of the face or upper part of the chest, neck, and arms and shoulders. Telangiectasias, these all are mainly cosmetically aesthetic importance. Telangiectasias appears as a small hair-like lesions, the prominent blood vessels over the skin. Usually this is appreciated in the Western countries or fair individuals. Palmar erythema, this is limited to hypothena or thenar eminence. As you can appreciate is the redness of the palmar aspects of the hands. This is because of the increased vasculatures. And one of the most commonly seen is the varicosities. That is then bilateral varicose veins or few times even unilateral because of the gravid uterus pressing over the inferior vena cavas. So this may result in the varicosities of the saphenous, vulvar or hemorrhoidal varicosities. And edema, both lower limbs or unilateral or bilateral lower limbs or extremities of the face can be seen. This is usually presents with asymptomatic edema and they are non-pitting. Flushing, this is commonly seen in the fair individuals, usually the redness of the face or the malar prominence and the nose. Cutis murmurata, this is nothing but you can see that reticulated pattern of the blood vessels seen on the legs. Hemangiomas. These hemangiomas are subcutaneous endothelial or even the gliostomas. This is seen in 5% of the cases. This is also basically cosmetically oriented, nothing much of importance. Few times this may bleed, or a few times this may require some surgical excision such as an electrocautery or radiofrequency or any other destructive procedures which we do in dermatologist. Granuloma gravidarum, this is nothing but pregnancy epilis. You can see in the photograph the small swelling, that is an reddish purplish papules seen in the first half of the pregnancy, and this occurs as an anterior mandibular or maxillary gingiva. These all are midwise may surgical excision. Next is the structural. One of the commonest complaints female presents to, especially with the dermatologist, is the stretch marks, that is called as an stria distantile or stria gravidarum. So this usually presents in the third trimesters. About 90% of the pregnant ladies will have this stretch mark. This is due to the physiological factors, hormonal such as relaxin or estrogen and corticosteroids, which causes thinning of elastic fibers. This appears like violaceous line streaks in the 6th to 7th month, evolve into the linear depressions of fine wrinkles, and they become more prominent mainly on the abdomen, breast, or thighs. Or a few times this may fade postpartum, or it may take months to years to fade. So this is basically a cosmetic importance. We can give not 100% of the result as like previously it used to be. Like we can give 40 to 60% with different procedures. What we do in our OPD setup, like something microdermabrasion, microneedling, radiofrequency, or few times even the lasers may add up to about 20 to 30%. At most, we can give to 60 to 80% with carbon dioxide lasers or with MNRF. And the next one is the molluscum fibrosum gravidarum, a simple called a skin tax, starts appearing in the flexors of the body, mainly the neck and axillary areas, multiple skin tags. So pruritus in pregnancy, this is most commonly affects in 20% of the patients. Common pruritic locations are mainly the scalp, anus, vulva, or abdomen, skin. This appears in the third trimesters. Patient with more generalized pruritus must be evaluated for other conditions, that is intrahepatic cholestasis of pregnancy, may be related to the dermographism or urticaria, which are more common in last half of the pregnancies. So this is very simple to treat. Like simple moisturizer can be used, or simple exposure to sunlight relieves the symptoms, or any of the FDA classification C and B group of drugs such as an CPM or loratadine or cetirizine can be used in severe cases. So as I told you, many of the drugs which falls in B and C groups can be used to relieve the symptoms, mainly the pruritic conditions of pregnancy. That may be simple CPM or hydroxyzine or cetirizine or loratadine or desloratadine. Any of these drugs can be used during pregnancy very safely. Diseases which worsen during pregnancy, these are the list which get worsened during pregnancy. This includes infections, any viral infection, bacterial infections, fungal infection can get worsened, mainly the varicella, trichomonas, leprosy, herpes simplex virus, human papilloma virus, condyloma accumulata, candidal vaginitis. Some immune system diseases that are SLE get worsened, connective tissue disorders such as an Ehlers-Danlos syndrome, excessive bleeding during your cesarean section can be seen, or wound gaping after cesarean section may be seen in pseudoxanthoma elasticum, and metabolic disorders such as an ectodermatitis enteropica, porphyria cutaneous tarda, or dermatomyositis. These all get worsened during pregnancies. So some common specific dermatosis in pregnancies. These are 4 important mainly the pemphigoid gestationis are also called as an herpes gestationis. Polymorphic eruptions of pregnancy are also called as pruritic urticarial papules and plaques of pregnancy, commonly called as PUPPP, which commonly we write. Toxic rashes of pregnancy, toxic erythema of pregnancy, late onset prurigo of pregnancies. And one of the most deadliest is the intrahepatic cholestasis of pregnancy, that is pregnancy with jaundice. You are all aware of it, with having bad prognosis. is also called as an cholestasis of pregnancy, prurigo gravidarum, jaundice of pregnancy, obstetric cholestasis. And finally, the atopic eruptions of pregnancy are also called as prurigo of pregnancy, prurigo gestationalis, early onset prurigo of pregnancy, papillar dermatitis of pregnancy, eczema of pregnancy. So this intrahepatic cholestatic pregnancy is, as already told, that genetically linked hormonal dependent variable cholestasis. Usually patient presents to you with itching and there is no lesion seen on the examinations. The patient usually presents to us with the third trimester, and most commonest presentation in this pregnant lady, about 80% of the patient presents to us with common itching. Most important is pleuritic gestational conditions, steatoria often noted by patients and followed by vitamin K deficiencies. This usually occurs after delivery, postpartum. The itching subsides after delivery, but this may recur subsequently in subsequent pregnancies or after restarting the oral contraceptive methods. This has increased fetal complications. The main element is reduced excretion of bile acids. This causes increased sebum levels in serum. There is a mutation in genes coding bile transport proteins, and high levels of sex hormones prevent the excretion of bile acids. Cholestasis affects estrogen, progesterone, and metabolites. And the other additional is the selenium deficiencies. Mainly presents, as already told, presents with sudden or acute onset of itching, intense itching, generalized pruritus, mainly concentrated on the palms and soles. Then later on, this spreads and becomes generalized. There are secondary changes from subtitle expressions and prolonged prurigo nodularis. This should be differentiated with other causes of secondary pruritus in pregnancies, and even the viral hepatitis should be differentiated. So this is the photograph showing simple pruritus, which becomes more enhanced, and multiple nodules will be seen on the pruritic area, leading to the prurigo nodularis. Patient presents, this pruritus presents until delivery, and then it resolves spontaneously within days. Recurrence during subsequent pregnancies is almost amount to 45 to 70% of the patients, and recurs with oral contraceptives after postpartum. So here the importance is the fetal risk. There is an increase in premature births, which accounts to 20 to 60% of the fetal. Intrapartum fetal distress may be seen in 20 to 30%, meconium staining of amniotic fluid, abnormal fetal rate, and even it may account into the fetal loss, accounting to 1 to 2% of the pregnancies. So laboratory diagnosis, mainly the gold standard is the estimation of serum bile acids, which is almost increased to 3 to 100 times elevated. And in recent studies, it was seen that urine bile acid have been 100% sensitivity estimation, almost specificity of 83%. So other parameters like LFT, total bilirubin and direct bilirubin are increased. Transaminase and alkaline phosphatase are also increased. Direct immunofluorescence studies are not productive, and even histopathology is non-specific. Coming to the treatment, first and foremost important is topical emollient applications throughout the pregnancy. And if it is not controlled by emollient application, we can start on oral antihistaminic, either loratadine or cetirizine, which are very safe in pregnancy. And the important drug is UDCA, that is urodeoxycholic acid. Then the second line of drugs can be started as dexamethasone, chlorhistamine. Then other recommendations in this includes weekly monitoring of the CTG, that is a cardiac topography, that to monitor the heart rate and detect the early sign of fetal distress. And if the patient presents with jaundice, the maternal vitamin K can be given. Early delivery, so you have to terminate the pregnancy if the worsen the conditions, at least minimum at 36 or 37 weeks. Dexamethasone can be given at the 37 week for lung maturity. The important lies here is the multidisciplinary management. Here, management should be done with dermatologist, hepatologist, gynecologist, and even the pediatricians. So the combined effect should be made to save the fetus during the pregnancies. Next is the prurigo of pregnancy or prurigo gestationis or early onset prurigo of pregnancy. So this is most commonly seen dermatosis about 50% of the pregnancies. This begins as in simple pruritic conditions, and this may give rise to eczematization. Two types of lesions can be seen. They are the eczematization of the pregnant lady or papular lesions with atopic diastasis. Atopic dermatitis is either de novo or maybe the pre-existing lesions. These are seen mainly in the early pregnancies and tends to recur. So clinical features, eczematization mainly seen majority of the patients with atopic lesions, majority of the 2/3 of the cases, and prurigo type are seen in 1/3 of the cases. This may involve the atopic sites such as face, neck, or the flexor aspects, mainly the body flexors, the axillary areas, or the cubital fossas, or plantar areas, or the extremities. This prurigo type involves mainly the second type, mainly the lesions, papular lesions may be seen on the trunk, extremities, and this classically prurigo lesions are small erythematous papules. I will show you the photographs of this. So this is what we see, the eczematization are lesions on the body and papular lesions on the abdomen. These are the E and P type of lesions. And these are the mixed type. You can see both eczematization and papular type of lesions. So basically, this has a very good prognosis, and recurrence may be seen in subsequent pregnancies. And the fetal risk, there is no fetal risk, may continue the fetus with good prognosis. Here, if we do the analysis, usually IgE, serum IgE is elevated, serum bilirubin acid, other parameters are normal, other than only IgE will be elevated, other functions are normal, such as direct immunofluorescence will be normal, skin biopsy shows normal, non-specific findings. This should be differentiated with polymorphic eruption of pregnancy that is mainly seen in late pregnancy, or intrahepatic cholestatic pregnancy. This is also seen in late in pregnancies, or microbial folliculitis. Treatment, first and foremost, is the counseling the patient and application of emollients. And if it is required, we can apply topical corticosteroid, which are safe in pregnancy, and addition of oral antihistaminics such as loratadine and cetirizine. Second line, if that doesn't come under control, we can safely give narrowband ultraviolet B phototherapy. And if not controlled, then can be used azathioprine or prednisolone in the late part of the pregnancies. So the next part is then pruritic urticarial papules and plaques of pregnancy, commonly called as PUPPP, or toxic clashes of pregnancy, or toxic erythema of pregnancy, or late onset prurigo. As itself tells, there are polymorphic lesions. There is urticarial plaques, papules, plaques can be seen. So this usually appears in the late onset of pregnancies and are self-limiting, associated with multiple gestation pregnancies and excessive weight gain, usually seen in late pregnancy in 85% or immediate postpartum in 15%, and they doesn't recur in further pregnancies. So these are the lesions. There you can see the morphology of the lesion, multiple urticarial plaques and few papules around the umbilicus, but here you can appreciate there is no involvement of the umbilicus. And urticarial plaques over the abdomen. So lesions are late in third trimesters, itching and erythematous plaques that coagulates into papules may coagulate to form plaques, classically found on the abdomen, sparing the umbilicus, and are found primarily in the abdomen striatus, resolves with delivery and rarely recurs. So fetus and mother are not affected by these lesions. So very safe during these lesions. So this is the macular lesions, these are targeted lesions, and this we can see the papules and erythematous tiny vesicles. So lesion results over the average of 4 weeks, no maternal mortality or morbidity, and even the fetus, there is no fetal risk, as already told. So serum IgE is normal, everything appears to be normal, even the serum bilirubin acid are normal, liver function tests are normal, direct immunofluorescence are normal, and histopathology appears to be, there is just a non-specific inflammatory cells that has an can be seen as a numerous eosinophils may be present. So this is histopathology showing the lymphocytic infiltration in dermal and epidermal. Differential diagnosis, this should be differentiated with the same mimicking conditions, that is urticarial pigmentosa or cancer dermatitis, drug eruptions, urticarias, and viral exanthemas. Treatment, emollients, emollients, emollients. Only the first important treatment is the application of generalized emollients. Next is topical corticosteroid on the affected areas and associated with and oral antihistaminics. The second line, after first trimester, we can give prednisolone and consider only induction in the labor in the closed full term. Pemphigoid gestation is the next one is herpes gestationalis or gestationis pemphigoid. This is an autoimmune blister disorder. This is mainly seen in the late pregnancy or immediately following the delivery. So this is associated with trophoblastic tumors, mainly the choriocarcinoma or iridoform mole. So HLA, halotype DR3 or 4 may be associated. Usually avoids first pregnancy but recurs in subsequent pregnancies. So these are the lesions. And very characteristically, you can see the involvement around the umbilicus. These lesions, rapid progression of generalized pemphigoid type of lesions, and this incidence is about 1 in 150,000 pregnancies. Bullous lesions tends to develop, and the diseases progresses and often not present in the first presentations. Lesions of this pemphigoid gestation spares the face, palms, and soles compared to the other type of lesions. Mucosal surface are involved and fewer than appears in 20% of cases. Very characteristics presence important is the involvement of the umbilicus. And of course, the other part of the areas may be involved like urticarial lesions. So the mean onset is usually the second and third trimesters in 20% of the cases. And in 75% of the cases, there may be flares up during the delivery or even after the postpartum period. Recurrence is seen in 8% of the patients, may provoke our subsequent menstrual periods or even after postmortem in the use of OC pills. So these are the urticarial rashes. You see well demarcated lesions. And here you can see that bullous, few bulla lesions, few blister lesions, ruptured bulla, which are very typical of pemphigoid gestationals. The typical periumbilical involvement. And these are the tensed blisters we seen in pemphigoid gestationalis. So urticarial rashes, abrupt onset of cutaneous lesions, and fetal risk, only 10% of the newborn develop mild skin lesions, which may resolve spontaneously. Increased risk of prematurity and small gestational age neonates. So this is urticarial lesions or vesicles in the newborn, lesions in the neonate. So here also the serum Ig is normal, serum bile acids are normal, LFT is normal. Here the important is direct immunofluorescence shows us linear C3 deposition at dermoepidermal junction. That is very confirmative, and histopathological we can see here the blister at dermoepidermal junctions. And this is the direct immunofluorescence. We can see the linear deposition of the C3 along the dermoepidermal junction, which is very characteristic and confirmatory evidence. So this should be differentiated with other urticarial lesions of pregnancy. And one of the important is fixed drug eruptions or bullous drug eruptions, which are commonly seen in as a drug eruptions. Treatment important is an emollient, topical potent steroids, and oral antihistaminics. And second and third trimesters, we can start on oral corticosteroids and termination of pregnancy at the last trimester and the full term. And third line, if that doesn't subside and the patients get more severe lesions, we can even start on rituximab or cyclophosphamide, methotrexate, and IV immunoglobulins, and cyclosporins in refractory cases. Then the next is pruritic folliculitis of pregnancy. That's nothing but then follicle-oriented papules, which are seen in 1 in 10,000 populations of pregnancies. This usually presents to us with the papules or pustules around the follicles. These lesions benign on the abdomen and spreads on the extremities. This may few times presents to with pruritic lesions, commonly in the third trimesters, and results after delivery. So usually increased incidence of fetal low birth weight and no morbidity and mortality in the fetus is seen. The next important is the pustular psoriasis of pregnancy. This is usually seen in the third trimesters. Flexures initially as erythematous patches, whole margin are studded with subcorneal pustules with the generalized. You can see here though that both lower limbs, upper limbs, and the abdomen are involved with erythematous plaques and studded with pustules. This resolves after delivery and may be recurrence is seen after subsequent pregnancies. Fetal risk involves the placental insufficiencies and even stillbirth and neonatal death. So early induction of labor is needed. So pustular psoriasis may be life-threatening to the pregnancy also for the maternal side, and many of these affected women has no previous personal history or even family history as seen in psoriasis. So recurrency is the subsequent pregnancies have been reported. Disease tends to remit promptly after deliveries. So laboratory studies, mainly there are some changes in the calcium level, phosphate level, vitamin D level, hypoalbuminemia, hypoferric anemia. There may be increased ESR levels, neutrophilia, leukocytosis. This is all are seen as blood investigations. So histopathology, we usually see the very important microabscess that is called as spongiform pustule of Koji, that is the microabscess formation and infiltrated cells in the epidermis and papillomatosis and parakeratosis. Important topical emollient, topical corticosteroid. Second line include safely the narrowband ultraviolet B and broadband ultraviolet B. Systemic corticosteroid, about 30 to 60 milligrams of prednisolone per day can be given. Cyclosporins can be used in refractory cases. Even if the pustules are sterile, some authors have used cephalosporins. Tumor necrotizing inhibitory factors, that is an adalimumab and etanercept infliximab can be used. Replacement of calcium, which has decreased, can be used. Fluids, electrolyte balance should be maintained, and the decreased levels of calcium, phosphate, and albumin can be used. So this is a flow chart where when we see the lesions with the primary lesions, only pleuret is there, no primary lesions are there. We have to suspect intrahepatic cholestasis of pregnancy, and only secondary lesions due to the scratching because of the secondary lesions such as an excoriation and prurigos are seen. So no specific investigations are supportive to the patient for the diagnosis. This can be with the absence of any skin lesions. If there are any skin lesions, the primary skin lesions, though they can be related to the pregnancy with the onset of lesions in the third trimesters, and you see the involvement of the lesions in trunk and limbs, we should consider the atopic eruptive of pregnancies. And in the late onset in the third trimester, this is in the early trimesters, that's the atopic erythematous of pregnancy, and the late third trimester, we have to suspect polymorphic eruptions of pregnancy and pemphigoid gestationis and other dermatosis if there are no lesions. So this is a comparative chart of then different specific dermatosis. Here, papules, plaques are seen in gestation, herpes gestationis, and usually seen on the trunk, and generalized eruptions sparing face and mucous membrane. Here, second or third trimester presentation, and here usually the small for gestations and neonatal pemphigoid gestations will be seen. Intrahepatic cholestasis here is commonly seen in third trimester, and baby may be preterm, and even fetal death may occur. Pruritic urticarial plaques and pregnancy, either the fetal complication or none, which are present in third trimesters. And atopic eruptions, here the fetal complications are none, and even the eruptive pregnancies or fetals are. Mainly the important you have to concentrate are on the pemphigoid gestationalis or intrahepatic cholestasis pregnancies, because there are more complications in the fetus. So this is the flow chart, which is the same. No fetal risk in the atopic eruptions of pregnancy, polymorphic eruptions and pregnancies, and pemphigoid gestationis may results in small for dead babies. So coming to the non-specific pregnancy dermatosis, this includes infections, inflammation, or autoimmune disorders, miscellaneous, and any of these infections, such as an viral, bacterial, fungal, and infestation, parasitic infections, may be non-specific. Inflammatory, that are the pustular probe, psoriasis of pregnancy, simple acne or rosacea, pityriasis rosea, urticaria, erythema nodosum may be inflammatory. Some autoimmune disorders such as SLEs, systemic lupus erythematosus, pemphigus vulgaris, and pemphigus foliaceus may be seen. Miscellaneous are the linear IgM dermatosis, autoimmune progesterone dermatitis of pregnancy, aggravative angiomyxomas. So coming to the common viral infections, as we all are prone, even the pregnancies, females are more prone for viral infections such as human papilloma virus. So this we have to give importance when there are multiple wards in the birth canal. So you have to consider elective cesarean section, otherwise they may land up in birth canal obstructions or neonatal laryngeal papillomatosis. Herpes simplex infections which may give rise to herpes genitalius, active herpes genital lesions is an indication for cesarean section. So we should right away directly take for termination of pregnancy at the full term. So any active lesions you should electively take for the cesarean sections. Varicella zoster, mainly the mother or even the neonate are more prone for fetal varicella syndrome. And HIV, that's a more common, you have to start on the ART treatment. Other complications include pneumocystic prophylaxis and cotrimazole therapies. So one of the most important is varicella with pregnancies. As you can see, the pregnant lady with the skin lesions, polymorphic lesions, they are the papules, fascicles, pustules, and few lesions are started healing up. These are the polymorphic lesions. So this may present in the pregnancy in 2 to 3 pregnancies per 10,000. So they have indirectly or directly effect on the neonate and even the pregnancy outcomes. Pregnant women who contact varicella in the last trimesters are at higher risk of severe pneumonia and even the maternal death. Varicella vaccines are usually contraindicated in pregnancies. This is the flow chart which shows us the consequences of the varicella infections during pregnancy and according to the gestational age. So here you can see the varicella before 13 weeks of gestation, the fetal varicella syndrome is just 0.4%. This increases with the maternal durations of 13 weeks to 20 of varicella syndromes increases by 2% and mortality up to 30% in first month of life. And severe varicella at any stage of pregnancy, they may be leading to intrauterine death. Varicella at the third trimesters of pregnancy, there may be maternal pneumonia, increasing risk of 10 to 20% of mortality, and infantile transmission, mainly in the first few years of life, or virus after the primary infections. Varicella greater than 5 days or before delivery, last 3 weeks of pregnancy, neonatal varicella may be seen in first 4 days of birth, and varicella between 5 days and antepartum of 2 days, neonatal varicella has a risk of 20 to 50% and mortality up to 20 to 30%, or even severe form of neonatal varicella. And this is the management of maternal and neonatal varicella. Maternal, irrespective of the duration of the pregnancies, acyclovir is very safe in pregnancy. You can give in any trimester of the pregnancy if you see the maternal varicella. So you have to give varicella irrespective of the durations. 800 milligrams 5 times daily, 5 to 7 days. Or even it can given in the intravenous acyclovir 10 to 15 milligrams per kg body weight at 8 hours for 5 to 10 days. Fetal varicella, if congenital varicella syndrome is there, no use of giving any drugs because it has a high mortality rate of 30%. Neonatal varicella should be promptly treated with intravenous acyclovir. Next is leprosy with pregnancy. That itself is a big chapter. The drugs should be not withhold, should be given anti-leprosy drugs. So few times even the drug resistance are seen. And if they land up in any steroids should be given for reactions in leprosy at the dose of 40 to 60 milligrams for 2 weeks, followed by steady reductions in the dosage in second and third trimesters. And one of the commonest seen, and most of our gynecologists are referring to us with simple complications of scabies. So no hesitant in putting anti-scabitic drugs. So it's a common itchy conditions, mainly spread in the web spaces, flexor areas, abdomen, around the umbilicus, or near the genital areas. Mainly nocturnal pruritus will be there. It means itching increases at night, and some other members of the family have similar complaints in the family. So no harm in giving permethrin. You can give permethrin in 2 doses repeated in 1 week apart. If not subsided, the second line benzyl benzoate, but avoid lindenate, that is, and systemic ivermectin. And usually the pruritus will be there for weeks or 2 weeks, 3 weeks, even after the complete cure, never counseling the patient is very important. Give supportive treatment with antihistaminics such as CPM or loratadine and cetirizine. Then commonest is the candidiasis, orovaginal candidiasis. So patient usually presents with vaginal vulval irritations. This usually presents with severe pruritus or warty, curdy lesions in the vagina or the oral cavities. Patient may present with dysuria and yeasty odor. Treatment is systemic, and even the vaginal pessaries with antifungal will help the conditions. Next is the inflammatory impetigo herpetiformis, usually presents in the third trimesters. As already told, may present in the flexure cinceli, that is in erythematous. Patches or margins are studded with subcorneal pustulosis, that is generalis pustular psoriasis. They resolve rapidly after delivery and may subsequently recur in the subsequent pregnancies. So fetal risk, mainly stillbirth or neonatal death, or early induction and labor is needed in this generalized pustular psoriasis. Treatment: emollient, topical corticosteroid, or lesions involvement of areas can be applied corticosteroid with low and mid-potent steroids. Patient can be subjected for the narrowband ultraviolet B or broadband ultraviolet B, which has good results. And third line, mainly cyclosporins, systemic corticosteroids, and immunomodulators such as then adalimumab or etanercept can be used in third trimesters. Next commonest is the patient presents with worsening of acne and rosaceas. Usually this patient acne subsides in the early pregnancy, but in the second or third trimester, patients presents with more acneiform eruptions, mainly on the face, upper part of the chest, upper back, with more second and third grade of acne, mainly in the pustules, nodulocystic acne. So we are very safe in erythromycin or azithromycin can be given after first trimesters, and a few, because of the passive transfer of maternal androgens, even the neonate will have acneiform eruptions, mainly on the face and nose. Usually we should counsel the patient regarding this. No active treatment is needed for the neonate. For the mother, we can give topical anti-acne preparations, and contraindications are the steroids and topical retinoids should not be given. And next is then very simple conditions which you can diagnose in when you look at the lesions in clinically diagnosed case of pityriasis rosae. These lesions appears mainly on the upper part of the chest and back, the inverted Christmas tree pattern, oval type of lesion with peripheral rim of fine scales. This should never be confused with the similar type of lesions, that is tinea corporis or psoriasis. This usually appears as an inverted Christmas tree pattern, oval type of lesion on the upper back and upper part of the chest. So usually this has very less fetal or maternal morbidity or mortality. Urticaria, very simple lesions, urticarial lesions seen on the pregnant lady can be treated on OPD basis, never to be confused with polymorphic eruptions of the pregnancy. This is commonly seen in pregnancy. Simple emollient or antipruritic drugs such as calamine lotion can be applied. If doesn't subside, we can supportive treatment with antihistaminic can be given. And if not subside in the after second trimester, we can give systemic prednisolone steroid after second trimesters. The next is the erythemanodosum. Here you can see the multiple nodular lesions on the abdomen. Usually pregnancy or even the OC pills may trigger this nodular lesions. Erythemanodosum usually appears in the 6 to 8 weeks of pregnancy. This is associated with fever or arthralgia, and important is the rest, leg elevation, and analgesics, and counseling the patient. Last is the systemic lupus erythematosus. These are usually flare up in 60% of the pregnancies, can cause spontaneous abortion, fetal loss, usually associated with preeclampsia or preterm baby or low birth weight babies. Neonatal lupus erythematosus can be seen on the neonate, that is an annular lashes on the face. Even the neonate which is born may have congenital heart block in 2 to 3% of the neonates born. So pemphigus vulgaris may also present in the pregnancy. So this usually presents with the spontaneous abortions, so fluid-filled lesions, flaccid bulla appears on the any part of the body, upper part of the chest or back, usually fishy in odor, and this may lead up in the stillbirth, and you have to terminate pregnancy at the early third trimester or full term. Elective cesarean section can be planned. Neonatal pemphigus also noted in these patients with maternal pemphigus vulgaris. Perinatal mortality of 12% of can be seen in neonate. These are my references. Thank you.
Thank you, sir. Thank you so much. That was really an elaborate talk. And I'm sure all our doctors are enlightened. Yeah. Thank you, sir.
Thank you very much, madam.
Yeah. So now we move on to the next session, that is the panel discussion on GDM. We have with us Dr. Asha Bakshi ma'am as the chairperson and Dr. Arpita Gandhi ma'am. Is Asha Bakshi ma'am here? She said she had to leave. Ma'am, are you there?
I'm here. Yes, I'm here.
Yeah, ma'am. Yeah, welcome, ma'am. And it's my Arpita Gandhi ma'am is also here with us, and they are the chairpersons for the GDM panel. It's indeed a privilege for me to introduce Asha Bakshi ma'am. She is the lead consultant at Dr. Asha Bakshi Fertility Center, which is in association with Motherhood Hospital at Indore. She is currently the secretary at ISAR, member of Executive Committee AIC RCOG West Zone. She is the founder chairperson of MPIH and MPSR, member of Advisory Committee PCPNDT Indore. Ma'am, we welcome you, ma'am. And we have with us Arpita ma'am, who is a senior consultant, and she's the founder person of KSOGA-Gyaan Sangam Society at Jharkhand. I request Asha ma'am to introduce today's moderator of the panel discussion, Dr. Jyotika Desai ma'am, who is our senior consultant at Bangalore.
Thank you very much, Rachna, for the kind introduction. And it is really nice to be on this platform of KSOGA. I've been to this, I've attended one of the KSOGA conferences. I was invited by Dr. Pratap Kumar in Manipal, and I was very impressed by the whole, the way you people are working, very interactive and very intellectual people, I must say. And so nice that Dr. Nagraj and Dr. Hiremet and Dr. Vidya Tobi have been presidents, and especially recently Vidya, who is my close friend, has been president, and she is somebody with deep knowledge, very humble and very active. So my best, and I'm sure I wish her all the best for her future endeavors, as I think she's going in for vice president. And then I would like to congratulate Dr. Bharti also, because she's organizing this conference, and she's the current president of KSOGA, which is a very prestigious thing. And she's also, again, a very, very active and dynamic person. And I wish her all the best for her elections. And today I'm very honored to be the chairperson of this this panel, and this is a very interesting topic on gestational diabetes mellitus, which is of interest to every obstetrician and gynecologist. And to moderate this session, it's no one else but Dr. Jyotika Desai. Can I have her CV? Can I have Dr. Jyotika Desai's CV, please? Dr. Jyotika Desai, I know because she's a very good friend, and especially she has been the scientific chairperson of AICOG that was in Bangalore. And after that, following that, we had to do the conference. So lots of tips we used to take, and I used to always say that she's so intelligent, and that is Jyotika. And coming to her CV, she's senior consultant at PR Desai, Bangalore, DNB teaching and faculty at Bangalore.
Asha?
Yes,
Let us not go through it because we are already very late. So we'll just skip all that.
Yeah. But Jyotika,
Thank you so much.
I really admire you, and I'm sure you are going to do good justice to this panel, and there should be lots of interactive discussions. So all the best for the
Thank
panel.
you so much. Thank you.
And the panelists are on to you, ma'am. Yeah, we have 5 panelists on board.
Yeah, can
One
you have
panelist has left,
Can
ma'am.
you have Dr. Aruna's CV, please? Yeah, Dr. Aruna Bidupalli is from Anantapur, and she is the Managing Director of Snehalata Hospital, a super specialty hospital. Welcome, Dr. Aruna.
Thank you.
Dr. Reena, can we have Dr. Reena? Okay, yeah. Dr. Reena is from Kollam, Kerala. She is in government service, and she is the past president of KGMOA. I don't know what that means. I think it is Kerala General Government
Medical Association.
Government Medical Officers.
Kerala Government Medical Officers Association.
Okay, fine. Thank you, dear. So she has been the president in from 2020 to 22, and she's also the state managing editor of KGMOA 23 to 24. Welcome, Dr. Reena. Can we have Brajbala, please? Dr. Brajbala. Yeah. Dr. Brajbala is the past president of Indore OBG Society and also the managing director of Life Care Hospital, which I think in Indore. She's, of course, she's got a lot of a very impressive office bearer's profile. A very warm welcome to you, Dr. Brajbala. Can we have Sangeeta Garg, please? Yeah. Dr. Sangeeta Garg is from Roorkee, attached to Sanjeevani Hospital. She also has been the past president of Roorkee branch of Foxy from 2021 to 2022. Sangeeta, a very warm welcome to you. Can we have Dr. Umas, please? I hope you all don't mind. I'm making a very brief introduction of you all because we are very much behind schedule. And Dr. Uma is a laparoscopic surgeon from Karur. She's been practicing from 20 years. And yeah, that's it. She's an ART specialist. Welcome, Dr. Uma.
Thank you.
Okay, so today, can I share the screen?
Ma'am, Dr. Brajbala is not here with us, ma'am. She had to go. She had an emergency and she had to go. The others are there.
Okay, they have to share the questions, and whenever Brajbala's question comes, I'm sure Aruna, Reena, Sangeeta, Uma will jump to it. Okay, let's hope. Yeah. So let's start the session, dear. Let's hope we can finish as fast as we can.
Yeah, ma'am. Fast track.
Now, this is, we all know the definition of GDM, carbohydrate intolerance with recognition or onset during pregnancy. And it is also classified as A1 GDM when GDM is controlled with just medical nutritional therapy without the use of any medicines, and A2 GDM when medication is given to control GDM. So this is important, especially when we are compiling statistics. Now, this was from the NRHM 5 between 2019 and 21, but the incidence of the prevalence rather of GDM is very skewed, because though they interviewed about 26,131 pregnant women, they've only taken those who said that they had GDM into consideration, and this gives the incidence of GDM in India as 0.80 per 100 pregnant women, which is dismally low compared to what it is really. And here they got an incidence of 4.88 in Goa, the highest, followed by Kerala, and then the rest of the states are in 1 or less than 1. Now, this was from, they've taken 2,393 pooled studies were analyzed in 5 different zones of India, and they found that the prevalence is 13%, which is more like what we see every day, ranging from 9 to 16%. And the commonest test which was performed for screening was DIPSI, followed by the IDPSG, and again, of course, WHO2. And the rural prevalence was a little lower, about 10%.
And this is from the BMC Public Health, published in February 2024. Now we come directly to the case. A primary gravida aged about 36 years. I'm sure in the urban areas we are seeing women who are coming for the first pregnancy well past 35, 36 years. And of course, again, we see quite a lot of them being obese. So this lady also had a pre-pregnancy BMI of 35. She comes to the clinic having missed her period by 10 days. Now, before we come to GDM, let us just come to this particular point of relevance of pre-pregnancy BMI in GDM and otherwise too. Well, whenever the pre-pregnancy BMI is elevated, it has an independent increase. It causes independently an increase in the risk of GDM, especially when the maternal age is advanced, like in our patient. Again, this is something which is not very frequently understood, but very important to know that excessive weight gain in the first trimester is associated with a higher incidence of GDM, regardless of pre-pregnancy BMI. So even if the pre-pregnancy BMI is on the lower side, if the patient puts on an excessive weight in the first trimester, normally we either lose weight or we put on very minimal weight, but an excessive weight gain indicates that she is going to definitely get GDM. And mind you, this is regardless of the weight gain which she has gained, weight which she has gained throughout the rest of pregnancy. So this is something which all of us should keep in mind whenever we are seeing our pregnant patients. Now she had a BMI of 35. So how much of weight gain should she have in this pregnancy? Well, this is very simple. We should have it on our tables so that when any pregnant woman first comes to us for booking, we should also have a height calculator so that we can give her her BMI. And then, because she would have most of the patients in our places, they come at 6 weeks or just having missed their period. So the pre-pregnancy BMI will be very close to what the weight is during that particular visit. So we can easily measure come to a conclusion about what the BMI would have been. So in this patient, because her BMI is 35, she can put on only about 5 to 9 kilos. It's not important just writing it in the card, the antenatal card or the paper, whatever you're using. It is important to impress upon the patient also that she cannot eat as she pleases and put on weight as she pleases. The optimal weight gain is only 5 to 9 kgs. And we keep monitoring throughout the pregnancy. So this is just by the way, because it's important and it has a relevance to GDM. Well, do we need to screen? There's no doubt about it because it has serious risk both to the mother and then the fetus and neonate, not only immediate during pregnancy and all, but also later on in life. So this is very important that children born to mothers with GDM have a higher risk of developing cardiovascular disease, childhood asthma, high refractive error in the eyes. We now see a lot of children having contact lenses, ADHD, and psychiatric disorders apart from developing type 2 DM. So yes, we need to screen. And also we need to screen because there is an intergenerational transmission of GDM. Pregnant women with obesity, with diabetes, they give rise to offspring who develop diabetes later on in life. And these offspring who have developed diabetes again will give rise to babies who will again have developed diabetes. So this is like something we're perpetuating diabetes in our population. Dr. Aruna, I request everybody to be very brief in their answers so that the point is given and we don't waste our time. Thank you for cooperating. Now, what are the risk factors for GDM, Dr. Aruna?
Yeah, good evening, madam. This elderly age is mostly seen nowadays.
Yes.
And obesity, family history with the father or mother are having diabetes, and
Yes,
the previous,
very good.
previous medium,
yes,
and previous big babies. Nowadays PCOD, because of PCOD, take
yes,
treat, they also get more
perfect.
yeah. Because of decrease of physical activity and because of modern lifestyle, taking junk food, all these things they are.
Yes, and because of hypertension also, which can be added to it. So we know that most people who are affluent, who are obese, who do not do much activity, tend to become tend to develop GDM. Now Dr. Brett, she's not there. Any one of you can take the question. How will you screen for GDM? Who's answering? Or shall I answer myself? Yes, no? Okay, since nobody is answering, I'll answer. Now, there are so many different ways of screening, but the most important take-home point is screen. Whether you do DIPSI, whether you do WHO, whether you do OGCT, whatever you do, please do it, because that is important that we do it. Now, if you're doing RBS, if it is 200 milligrams, you repeat the next day because she would have eaten a very heavy meal to confirm it that she has over diabetes. Now, if the fasting blood sugar, because quite a lot of studies do show that fasting blood sugar is very important. If it is more than 92 actually, according to ACOG, if it is 92, it is GDM, and more than 126, all of us know it is over DM. But the false positive rate is almost 30 to 57%. So it is better that we don't take the FBS as the confirmatory screening test. Now, what about the O'Sullivan's 50 grams 1 hour oral glucose challenge, which came much earlier? Of course, 180, more than 180 is GDM, 140 to 179 is suspicious of GDM. Again, that is not, quite a few people still do it. I've seen the reports, but it is not the ideal test. Then again, WHO, fasting. There, 140 at 2 hours is GDM. Now, the non-fasting 2-hour glucose after 75 grams is the DIPSI test. So what does that say? Well, that's the advantages with this is, one, that the patient does not have to be fasting. We know from studies that less than 10% of our antenatal patients, especially in our country, come fasting to the hospital. That's one thing. Then again, the pickup rate is quite high compared to the 2-step. It saves time. She doesn't have to come again and again. It saves cost, just one test. And again, it reduces repeated invasive sampling and it avoids repeated visits. And not only that, it has been approved by the Ministry of Health, Government of India, by WHO and by FIGO too. So how do you interpret it? Now, all these were Dr. Brajbala's questions. So if it is more than 200, the 2 hours, all of you are doing it. So I'm going to quickly go through it. If it is more than 200, it's confirmed whether in pregnancy or outside pregnancy, it is diabetes. If it is between 140 to 199, then it is GDM. And if it is outside pregnancy, we call it impaired glucose tolerance. But if it is between 120 to 139, we have a specific term in pregnancy called gestational glycemic intolerance, which we do not use in the non-pregnant state. And if it is less than 120, it is normal anytime. So the term IGT, impaired glucose tolerance, should not be used to indicate any glucose intolerance in pregnancy. This is specifically mentioned by Dr. Sheshaya. Now, whether we do capillary blood glucose or venous plasma glucose, whenever you take a blood sample from a vein, it is the venous plasma. And when you do it with your glucometer, it is capillary. There are any number of studies which show that there is no difference between capillary glucose and venous plasma glucose. The only thing is that you must have a glucometer which is of high precision, and it should have, and continuous quality assurance procedures are followed. This is very important. Now, in case, the patient has already purchased a glucometer and you're not sure whether about its quality, she can bring it to the hospital. At the same time, you can do a venous sample or your glucometer, which is a sort of precise one, and do with hers and see the difference, whether it's the same or there is a difference. And you can tell her that maybe it is 10 milligrams less in her glucometer or more in her glucometer, take it accordingly. Now, the common ones which have been sort of preferred are the One Touch, the Omron. So these are the ones which are usually, and Accucheck. These are the ones which are usually preferred. Now, when to screen, Dr. Reena?
Yes, and it is if any antenatal patient at booking visit, we have to screen. And we have to repeat the screen test when in second trimester around 24 weeks and in last trimester at around 32 to 34 weeks.
Absolutely. Thank you so much. Now, Dr. Reena, again for you. Why should we do it in the first trimester?
Because one, we can detect other over diabetes. And,
yes, one reason. One reason is you can pick up over diabetes. What is the second reason?
Other one is insulin is first detected in fetal pancreas at even at 9 weeks. And fetal hyperinsulinemia in response to maternal hyperglycemia is occurs by 16 weeks. So we can detect the hyperinsulinemia, the hyperglycemia at this time, and we can intervene at this stage itself.
Yeah, it is very important because once the fetus in its embryonic state is exposed to high blood sugars in the mother, epigenetic changes happen in the fetus. And this leads to accelerated growth despite good metabolic control in later pregnancy. That is the reason why we have to do it in the first visit. There is another very interesting, why is the DIPSI test sometimes normal in the second trimester and you cannot pick up a GDM? Can anybody tell that? Well, this is called the fetal glucose steal phenomenon. Exactly what I told you earlier. What happens is when the fetus is exposed to high blood sugars in the mother and you get a positive DIPSI test in the first trimester, and you know that she is a GDM or she's an overt diabetic. Okay. Now, what happens is the fetus, the pancreas is stimulated. It produces a lot of insulin. So there is hyperinsulinemia. So what happens? You know that glucose passes through the placenta very easily towards the fetus. So the fetus siphons the maternal glucose and then maternal blood sugar levels become lower. So what happens then is you have a situation where the mother's blood glucose levels are lower, normal range, but the fetus shows macrosomia and it shows hydramnios. Now, this is one reason why we have to do it in the first trimester and not miss out. Of course, if the patient doesn't come, we have no choice. But this is one reason, which is called the fetal glucose steal phenomenon. Right. Dr. Sangeeta, what about HbA1c? Do you believe in doing HbA1c at booking or during pregnancy? Both. Dr. Sangeeta?
Yes, good morning, ma'am. Good evening, ma'am. We should do HbA1c at the time of booking or the first visit because it helps to differentiate it between the gestational diabetes mellitus and the previous diabetes mellitus.
Excellent. Now, okay, now if it is high, I just put a problem to you. If the HbA1c when at booking is 11,
so
do you advise termination?
We should go for the NT&B scan on aneuploidy markers because congenital malformations are very much increased when this HbA1c is very high. So we can advise termination if there are some anomalies are detected.
Yeah, exactly. Very correct. So if the HbA1c is even 11 or 12, do not advise termination. Why? Because the risk of congenital malformation is 25%. What does it mean? It means that 75% of the babies are normal. So give her the benefit of the doubt. She may have conceived with great difficulty, especially one person who's not, I mean, this is not GDM, but I'm just coming to it, who's an uncontrolled diabetic. So, you know, we have so many tests, like Dr. Sangeeta said, we can do them, find out if there is an abnormality and then offer termination with justification. Okay, I'm asking you now, do you believe in doing HbA1c during pregnancy?
No, not. It is not very efficient after second or third trimester because it does not help in controlling or managing blood sugar level in second and third trimester. It is useful only in the first trimester, especially.
Yes, it is good at booking only. We don't do it because there are some reasons. One, if there is anemia, if there is hemoglobinopathy, the value is less. If there is, and because the RBCs have a rapid turnover in pregnancy, normally the turnover rate is 120 days. But in pregnancy, it can be as less as 100 days. So you cannot depend upon HbA1c during pregnancy. So there's no point doing it. So let us not do it at all. Only at booking, as Sangeeta said, yes, you have to do it. Dr. Uma, coming back to our patient, the 2-hour blood sugar, the DIPSI test was done, and her sugar was 135 milligrams per cent. Now, what is the diagnosis and what is the next step?
According to DIPSI, the interpretation is gestational glycemic intolerance she is having.
Perfect, very good. So
And
how will you manage?
the cornerstone is counseling. We have to counsel her regarding MNT, meaning diet, exercise, weight management, and self-monitoring of blood sugar level. And
Yes,
like
of
we have
course.
to advise her what diet she has to take and how much calories she has to take.
Yes,
And we
we'll
have to
come to it.
look
We'll
into
come to it.
look
Yes.
into her diet.
Yes,
And
ma'am.
we have to include the dietitian also in this program.
Yes,
And
very good.
accordingly, we have to decide the diet and we have to encourage her to do exercise also. The diet meal plan has to be based on the BMI. For normal weight person, the weight gain, I mean, the calorie calculation should be 30 to 35 kilocalories per kg, and for underweight it should be 35 to 40, and for overweight, the kilocalories the person has to take is 25 to 30 kilocalories per kg.
Very true. Now, sometimes the patients take it very seriously and they hardly eat anything. So they end up with a diet which contributes to only about 1,500 calories per day, which is not good at all because they can develop ketonemia. And when there is ketonemia, you know what happens? The IQ of the fetus suffers. So we need to tell. So the American Diabetic Agency Association has suggested that about 1/3 calorie restriction is indicated, not more than that. And even this is in obese women with GDM, so that they take at least about 1,800 calories a day. Now, this is about the healthy eating plate. All of us are aware of it, but I don't know how many of us follow it. The plate should be divided into 1/2 and 2/4. 1/2 should be filled with vegetables and fruits. It's so easy to advise, but when you look at the soaring price of vegetables and fruits, we wonder with what justification we can tell them unless they take a small quarter plate. And then, of course, 25% of whole grains and 25% of proteins, healthy proteins. So this is the healthy eating plate, lots of water and healthy oils again. Now, Dr. Aruna, what changes can you make in the diet? Will you advise?
Yeah. They have to split the breakfast and they have to take
breakfast. Very good.
Small meals, 2 or 3 times. That's all. And again, the frequent meals with quantity is less, and number and the quantity also should be reduced. They should avoid eating for 2 and this
Yes, very true. See, we know very well, you know, the older women in the house will always say, eat more, there's a baby inside. But that's not correct. You don't have to eat more. And again, quite a lot of women fast on Ekadashi or maybe in Ramzan. I think we should advise them not to do it because it is counterproductive. And one very bottom line is no juices at all. Fruit juices are only those who are convalescing from any illness, surgery, etc. Not for normal pregnant women. We should advise them to eat only fruits because it contains a lot of fiber, no juices at all. Okay, and then the dietary reference intakes. As DRI, it recommends about 175 grams of carbohydrate, 71 grams of protein, and of course 28 grams of fiber and a 2000 C. Each agency will advocate one type of diet. We have for our Indian women, we have to take an average and put all of them together. Yeah, you can continue, Aruna. What are the modifications?
They should not eat more than 1 small cup of rice in the day, and they have to avoid the bakery items like biscuits, cakes, and all, and fiber diet. Fiber-rich diet.
I think you mentioned 3 small meals and 3 to 5 snacks. Yes, and they should be fixed time. That's very important. We should tell them fixed time, not just any time. Because in case they are taking medication and insulin, then it just affects them. And of course, the protein sources for vegetarians would be paneer. We have to be careful of fake paneer also in the market now. Soya is available. Then again, of course, dals, lentils, sprouts, a whole lot of them, milk, all these are there. And then we tell them not to take more than 2 idlis, 2 dosas. I'm sure they can cheat us by having 2 tatte idlis, which are quite big. So we need to ask them everything all details when we are talking to them. Okay? And one big no for bakery items, because bakery items contain sugar and they contain trans fats and maida. All of them are out.
Right.
Yeah, this is something which I think we can tell them. The traffic light system, the red is what you should not eat. The yellow is what you can eat occasionally in moderation. And the green is what you can eat in any amount. In fact, we should have this in all our conferences so that, and the way we are having conferences left, right, and center, all of us are going to end up being obese and diabetic. Dr. Rajbala is not there. Okay. So who will take up this question? What about exercise? If nobody answers in 1 minute, I am going to take it up. Fine. So exercise has been proven to be beneficial. We all know that. Okay. Now, basically, there are no guidelines at all, especially for GDM. So what is recommended is we should do both aerobic as well as resistance exercise. Moderate intensity, not a very severe intensity. 3 times a week minimum for 30 to 60 minutes each time. If you're doing it every day, then 30 minutes is good enough. Now, what is important in diabetics is you do upper body exercises. You do upper body exercises. Swimming is very good, but not lower body exercises. This is a must, and which all of us should explain to our patients. And of course, whenever you climb, you lose a lot of calories. And whenever you lose calories, you're bound to have a lower incidence of GDM. And this study has shown that daily stair climbing, they didn't mention the number of steps, when compared with no stair climbing, it was associated with a reduction of 49 to 78% of GDM risk. So I think we should tell our patients to take the stairs. Pregnancy, even if they are pregnant, it makes no difference. Well, after 15 days of MNT, she returns. Now, Dr. Reena, how will you monitor her? Will you repeat the DIPSY?
Madam, I would like to do an FBS PGB for the patient.
Yes.
After every.
Very good. See, we must remember that once a DIPSY has come abnormal, we do not repeat it throughout pregnancy. The only way we monitor her now are FBS and PPBS. Yes, Reena. So her results were, fasting was 87. Mind you, she was following her MNT perfectly. And PPBS was 107. Dr. Reena, what next? What should you tell her? Dr. Reena? I can't hear her. Okay. We tell her. Yes, Dr. Reena?
She's not here. I don't know.
Okay. Now we continue. We'll tell her to continue MNT the way she has been doing till now. To check fasting blood sugar and PPBS every 15 days. To repeat DIPSY again at 24 weeks as advised. And to advise optimal weight gain every time she comes to you. Please check her weight and tell her to go easy on her weight. And of course, that is it. Dr. Sangeeta, what other preventive measures would you advise?
Should add additional medicines like folic acid up to 5 milligram daily to reduce neural tube defects. And we should start low-dose aspirin at 12 weeks after 12 weeks of pregnancy. To lower the hypertensive disorders later on. We should go for NT scan and double marker screening and PIGF placental growth factor if feasible. We should do.
I hope all of you all are doing the double marker screening.
Yes.
Yes, very good.
Now, obviously, she should stop smoking alcohol. And
yes, ma. Very good. Excellent. So now PLGF is not always possible in every center, but since this is a patient who has a high risk of getting preeclampsia, because not only she's old, she's obese and she's got GGI. So if possible, PLGF should be done. Good. Now, why is the NT scan important in a woman with hyperglycemia and pregnancy? Sangeeta, continue.
NT is very important in hyperglycemia of pregnancy because it not only causes aneuploidy detection, also we can find out major structural abnormalities which are common in pregestational diabetes mellitus, like anencephaly, meningocele, encephalocele. These all can be detected or we can pick up early because of this NT scan. It's very important.
Also, yes, that's true, Sangeeta. And also some of the abnormalities of the CVS can be picked up because
CVS,
whenever
we
the
can
NT
also.
is raised, you
Yes.
can suspect
Urinary
the CVS
atresia.
abnormality to appear later on. Okay? Yes, that's right. Any precautions with double marker screening in diabetics, Dr. Uma?
Yes, madam. PA, PPA, and beta HCG levels are significantly lower in diabetic women when compared to non-diabetic women. So when calculating risk for aneuploidy, this correction has to be made before the results are given. So the patients, we have to mention the particular patient is diabetic in the requisition form for double
Very
marker
good.
screening.
Very good. The thing is that most of the time we just sign, but the requisition is filled up by another person. So please, they will not know, they will not remember the importance, they will not know the importance. See that diabetes, GGI or GDM, whatever, is mentioned in the requisition form. Otherwise, the report cannot be trusted. Dr. Aruna, the patient has progressed. I can't see it actually in my screen. Can I get this out? I don't know whether I can get this out. Can I? Don't know. No. Okay. The patient has gone up to 20 weeks. Everything was under control. Now, what additional investigation has already come? It is the fetal echo. Now, tell me the importance.
Yes,
Yeah.
increase the risk of CHDs and hypertrophic cardiomyopathy. We can detect the CHDs and we can advise, we can take early decision about termination of pregnancy and enabling early genetic testing. And if there is nothing, if there is everything normal, then we have to we can reassure the patient if the scan is normal.
Very true, very true. See, some of the abnormalities can be picked up by a very astute sonologist in the first trimester. But this hypertrophic cardiomyopathy, asymmetric septal hypertrophy, all these develop later on. So a fetal echo should be done. Okay. Why can't we do the fetal echo after 24 weeks?
We can take early decision. Yeah.
Huh?
We can take early decision about
Any other reason? Any other reason?
Maybe the ribs will grow and the heart cannot be visible.
No, there is a reason. The ribs calcify.
Yeah, that's what
you can't see the heart properly. That is as early as you can, between 19 and 20, 21, 22 is the latest. Okay. Okay, DIPSI was repeated at 24 weeks as advised, and the result now was 157 milligrams. She was already on MNT, so now the MNT is not working. You know very well that the insulin resistance increases as the pregnancy advances. But Dr. Aruna, what would you like to do next?
Can go for the oral anti-diabetics.
Yeah, here we need to think for a minute, because most organizations, they recommend insulin as the first line of management. But in India, we still go for oral agents like metformin, right?
Yeah.
What is your opinion, all of you? Do you all go for metformin or you go for insulin right away?
We'll go for metformin.
Metformin, no? Yes, that's right.
That's
Yeah, Aruna. So now, yeah, this was a study that is just to tell you that with glyburide, you know, there has been, they found out that there was an increased risk of maternal weight gain, macrosomia in spite of taking medicines, increased NICU admissions, neonatal hypoglycemia, and of course RDS. So glyburide is out. So we are left only with metformin. And metformin is comparable to insulin according to this this Journal of Pharmacological Research, which was published in May 2021. And they did an analysis on 6,046 women, and they have compared it to insulin as comparable. Now, again, Aruna, what are the ideal candidates for metformin? Can you take this up? Or would Reena want to take it up?
So if the patient is obese, my metformin is the ideal drug. And the dose is 500 milligrams.
1 minute. I didn't get it. What was the first answer?
If the patient is obese.
The patient is obese in the non-pregnant state. In pregnancy, obese patient is not a ideal candidate for metformin. It is an ideal candidate for insulin. Okay. So lower BMI is an ideal candidate. Yes. What else? Continue.
Then dosage is 500 milliliters twice daily. For a maximum up to a 2 gram we can give.
Yes. So if the fasting is less than 100, then you can think of metformin. If it is
Okay.
if it is less than 20, if it is less than 20 weeks, ideally you'll have to think of insulin, not metformin. And it has a lot of advantages, like, there's no maternal hypoglycemia, no fetal macrosomia, and the patient has to take it easy, just orally. So definitely the compliance is so much higher. In which patients is metformin not advisable? Tina, you can continue.
In patients with placental insufficiency or associated with pregnancy-induced hypertension, preeclampsia, or IUGR, intrauterine restriction, metformin is not ideally advisable. In those cases, we will go in for insulin.
Very good. For the simple reason that metformin is associated with not macrosomia, but smaller babies. That is the reason why when the babies are already small, or they're going to be small because of these conditions, it's better that we don't combine the treatment for hypertension, preeclampsia with metformin. And which patients are more likely to need supplemental insulin? Reena, you are the...
Any maternal or fetal complications, as already we have discussed, it is any IUGR, macrosomia, hydramnios, so if there is any infection and very high blood sugar values, we will go in for insulin.
Yes, but before all these develop, if your patient has been on MNT and the fasting is more than 110, okay, it is better that you put her on insulin, not metformin. And of course, if it is earlier, we've already discussed it. And an obese woman, it is necessary that you put her on insulin. Now, when do we start insulin in GDM? First is at diagnosis along with MNT. MNT is like, the gold standard. Whatever the other medication, MNT continues. If the fasting is more than 120, as soon as you diagnose it, and if the 2-RPP and postpartum is more than 200. After MNT, if the fasting is more than 90, see, these are different guidelines. But please remember that the cutoff for fasting is 90. The cutoff for the 2-hour postprandial is 120. So you're giving her MNT, you're giving her metformin, still it is going on like this, then it is time that insulin enters. Now, what about the insulin requirements? Yes, they change in pregnancy. In pre-gestation, that is, if you're talking about over diabetes, first trimester, when you are starting, it is 0.7 units per kg per day. Second trimester, 0.8 units. Now what? Then the third trimester is 0.9, and of course in labor it is 1 unit. Now again, when you're giving insulin, you have to remember that 2/3 of the dose should be given in the morning and 1/3 at night. And this is a thumb rule, and we always have to readjust depending upon the blood sugar levels. Whereas in GDM, the requirement is different depending upon the time of onset and the severity of the hyperglycemia. Dr. Sangeeta, how often will you monitor the sugars and what sugar levels are you aiming at?
Is a case of on MNT or metformin, then we will do 4 tests: fasting, post-breakfast, post-lunch, and post-dinner. But if patient is on insulin, then we will go for 7 tests: fasting, post-breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner, and before going to bed.
Perfect. So most of our patients are on 4, they test their blood sugars 4 times a day. Can you mute Dr. Rachana? I think you need to be muted. Now the target, of course, is 90 to 95. I would rather go towards 90, not 95. And 1 hour is 140. Again, now there is a slight trend towards 130. 2 hours is 110 to 120. And the birth weight should, and these are the ADA guidelines, birth weight should preferably be less than 3.5. The self-monitoring has made a big difference by reducing the rates of fetal overgrowth, gestational weight gain, and of course the number of visits She just tests it. We give them a sheet where, you know, fasting, breakfast, post-breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner, midnight. All these are in a tabular form. She fills it up and she sends us by WhatsApp. And depending upon that, we always adjust either the doses or the insulin. Now, do we need to have such intensive monitoring and tight control for all patients? Why not weekly testing? Because quite a lot of endocrinologists advise them to come back after 15 days. I have seen, I get worried, but they are cool about it. Now, these are some studies which have shown that macrosomic babies were found to be 21.9% with 4 readings a day, mind you, 4 readings. But with weekly testing, it came to almost 30%. So I think we still need to have that many readings. Then gestational weight gain also significantly less was found to be with SMBG. Now in the MIG trial, better outcomes were seen when the fasting was less than 88. Now they're going further down and postprandial was less than 115. We say 90 and 120, they've gone further down and they found better results. Now, Aruna, in the 3rd trimester, any special counseling to be done to the patients?
Yeah. They have to deliver in the hospitals where the advanced neonatal resuscitation facilities are there.
Yes.
They should be available 24/7. And we have to discuss about the timings and mode of birth. When there is macrosomia, we should explain the benefits and risks of induction of labor, C-section, and all those things. And we have to tell them to count the kick counts, baby movements. And
one very important thing which all of us should remember is that all our pregnant patients should have a pre-anesthetic checkup. Doesn't matter if they don't go for a Caesar, but in case they land in a Caesar, it's always better the anesthetist has seen them. And more so with patients who have conditions like diabetes, GDM, and hypertension. So a pre-anesthetic checkup is a must. Yes? Now, Dr. Uma, coming back to our patient, what problems can she have during this pregnancy? We are dealing with maternal right now.
The mother can have a polyhydramnios, preeclampsia and eclampsia, abruptio placenta, preterm labor, instrumental delivery, cesarean delivery, and even postpartum uterine
hemorrhage. Yeah. True, very true. We're not going to deal with all of them, just one here. Now, our patient was put on metformin with sugars monitored 4 times a day. She was very compliant. She has reached 32 weeks now. Her sugars are well controlled, but she comes in premature labor. How will you manage her? Aruna, the question goes back to you. Why we are discussing this is, she's a GDM now, confirmed. Place of steroids and tocolytics in GDM. There's a big question mark, so I would like you to clarify.
The preterm labor, you have to give the steroids and this thing, the magnesium sulfate you have to give, the tocolytics like difedipine.
Yeah, see, what we need to discuss here is, we know that if she is a GDM on only diet or on metformin, she will need insulin. Why? Because the dose of insulin, if she was already on insulin, then the dose of insulin will increase by about 40% in the first 3 days and 20% in the next 2 days. After 5 days, the blood sugar levels come down. So ideal is you admit her, you give her the steroids and you monitor the blood sugars. That's very well. Of course, she's come in preterm labor, so you will admit her. But otherwise, even if there is no preterm labor and you have to steroid her, even in then, you must admit her and check her blood sugar levels before, after, and give her extra insulin according to the blood sugar levels. Now about tocolytics. Yes, you mentioned magnesium sulfate. Most of the time, magnesium sulfate, yes, because she's 32 weeks for neuroprotection of the fetus. But do we give magnesium sulfate for tocolysis? No, we give nifedipine most of the time. So nifedipine or indomethacin also is indicated for the simple reason that beta mimetics, they can cause hyperglycemia. So with insulin, with the steroids and with beta mimetics, you can create a very sort of dangerous situation. So avoid beta mimetics when a diabetic comes in preterm labor. And steroids are not a contraindication, please remember. Now, there are some fetal complications after 24 weeks, like prematurity, stillbirth, fetal growth restriction, and macrosomia. We will just deal a little bit about it. Who would like to take it up? How will you do fetal surveillance?
Risk of IUD is very high in diabetic.
If they are not controlled, okay? But the risk of IUD and stillbirth always remains in our minds, right?
We should advise patients to go for daily fetal movement counting, and it should be started from 32 weeks onwards, and to report immediately to the hospital if no fetal movements for more than 12 hours. And we can do NST or biophysical profile weekly from 32 weeks onwards, and ultrasound for growth parameters to be done every month from 28 to 36 weeks. More often, if baby is complicated by growth retardation or patient is developing preeclampsia. In these cases.
So we have to, when we are doing ultrasound for growth parameters, we have to chart it on a growth curve so that we will know whether the earliest indication of macrosomia. Now, Dr. Reena, can we predict stillbirth with fetal Doppler? We know very well with growth FGR, with fetal growth restriction, by your ultrasound, by your Doppler, by your NST, we can know that the baby is becoming bad. And with Doppler, especially with venous Doppler and all, you can terminate the pregnancy as soon as we have a positive wave. But here, can you predict?
No, ma'am. Usually, death IUD in diabetes mellitus is not due to hypoxia, fetal hypoxia. So there won't be any change in fetal Doppler. So
yes, very good.
Not an ideal investigation in GDM.
Yes. So the thing is, the death could be because of acidemia, and acidemia does not give rise to Doppler changes. So there is no role for fetal Doppler in routine GDM or DM, because it's not going to give us any additional information. Now about macrosomia. FGR is usually seen, one, if there is vasculopathy, which is not very common. Second, if there is superadded, superimposed preeclampsia, two, or if she already had hypertension in the beginning. And again, if she is on metformin and you've been very, very rigorous about her diet and her sugar schedule. So these are the three conditions where you can get FGR, or otherwise, of course, genetic and constitutional or macrosomia. Dr. Sangeeta, can you define macrosomia? Actually, yeah, come on.
Macrosomia we can define based on the birth weight. If it is more than 4,000 grams to 4,200 grams or 4,500 grams, is up to 4.5 kg weight. And we can also define based on growth. More than 90th percentile, 95th or 97th percentile for gestation.
That is the reason why we've given 3 here, because there's no consensus. Our babies are smaller, their babies are bigger. So for them, 4.5 could be what constitutes macrosomia. For us, 4 kgs itself is very big, right?
Our setup, it's big size.
Yes, ma'am. So, and then we see that in normal pregnancies, it's only 8 to 14, and in diabetic, it may be almost 45%. Now, what are the risks due to macrosomia?
The biggest risk due to macrosomia is the shoulder dystocia leading to the birth trauma, especially brachial plexus injury, fracture can occur, and birth asphyxia can occur. Intrauterine death 2 to 3 times more in cases of macrosomic babies, and babies can develop hypoglycemia, hyperbilirubinemia after birth.
Yeah, and one thing which I didn't mention here is you can have hydramnios and the additional complications of hydramnios. Now, which fetal biometry is a sensitive indicator of macrosomia, Dr. Uma?
Abdominal circumference is the best parameter, which correlates with the nutritional status of the fetus. Abdominal circumference more than the 75th percentile and a rising trend in the fetal growth pattern of scans done at 28 to 32 weeks predict fetal macrosomia.
Yeah, that is the reason why we need to have a growth curve, okay, for BPD, for HC, for AC, and for female length. And we should plot it on the graph every time the patient has a scan. So we know whether she is less than the 5th centile, she is in the 50th centile, or she's gone beyond the 95th centile, okay? So this is very important. So we should have a growth curve charts with us. Now this is just to show you how, this is okay. This is also okay. This is slowly going into the, it is still less than the 95th centile, but it is entering the 65th centile. Whereas here it has gone beyond the 95th centile. Same here. So we need to be very particular about this. Now our patient has reached 37 weeks. She responded well to the treatment which you gave for preterm labor. Sugars are well under control. Fetal monitoring with ultrasound shows a healthy, average-sized fetus. Weekly NST is reactive. Would you consider delivering the baby now, considering she is a GDM on metformin?
It is well controlled with the diet. You can wait till 39 to 40 weeks. And if it is
but
well
never go beyond 40 weeks. That is the bottom line.
Yeah, that we should not
that we must mention. Okay, yeah. Continue, ma'am.
Yeah. It is well controlled GDM on metformin. You can do between 39 and 40 weeks. And the well controlled GDM on insulin, then between 38 and 39 weeks. Poorly controlled GDM, we should decide between 34 and 39 weeks, depending upon the situation. And if the estimated weight is more than 4 kgs, definitely we can go for LSCS. In the absence of diabetic complications, and LFCS is best done at 39 weeks rather than 38 weeks.
Why do you say 39 weeks and not 38 weeks? Any particular reason in diabetes? The babies take a longer time to mature. Okay, that's one thing. And again, the estimated weight is 4 kgs. Yes, we say estimated weight is 4 kgs, and we are depending upon the ultrasound reports where it could be plus 500 or minus 500 in the third trimester. So it is a little dicey. So we have to
routinely can we give this steroids routinely?
Yes.
So,
no, I didn't get it. What did you say?
Routinely, can we give with this diabetic patient the steroids?
Steroids, no, ma. There's no indication at all.
Yeah.
Because there are a lot of side effects of steroids in pregnancy on the fetal brain. So unless our hands are forced, we should not give steroids. Please remember that, okay? Especially after 34 weeks. Before 34 weeks, yes, we are definitely sort of, justified in giving because the baby needs it for lung maturity. But after 34 weeks, we are not justified because the fetal brain is bigger, and when the fetal brain is bigger, it is very sensitive to small changes in vascularity. So what happens is when you give steroids, there are many, many trials which have shown, the ALPS trial, there are at least about 10 trials which have shown that the babies who were given steroids later on, that is late preterm, early term, because it says 39 weeks elective seizure, give steroids, don't give steroids. For the simple reason that these babies will have a lot of cognition problems and a lot of cerebral palsies because of that. So withhold it. And WHO says don't give it after this, especially in low resource countries, for the simple reason that infection rate is higher in babies when steroids have been given. So the babies, we may lose the babies because of infection rather than of TTS. Very few of them will have transient TTN, transient tachypnea of the newborn, which can be easily controlled. Very rarely you have RDS after 34 weeks. So as far as possible, withhold steroids when it's not really indicated. Well, our patient set into spontaneous labor at 39 weeks. Now, what are the problems you can face? How will you manage her? Sangeeta, can you take it up?
Patient can go into prolonged labor, or there may be fetal distress also.
Yes.
And the shoulder dystocia as patient 39 weeks, and macrosomia may be there. And there are, because of the big size baby, there are more chances of the instrumental delivery, like forceps or vacuum can be applied, or patient may land up into the cesarean section if CPG occurs. And after delivery, patient can have PPH also,
yes,
because of the uterine atony. In these cases.
So labor is not something, it's not a cakewalk for her. Now,
yes.
During labor, I've just tried to separate GDM on MNT and metformin and GDM on insulin. Most of the features, whatever we offer them, are the same, except that we have to have a partograph, continuous electronic fetal monitoring for both the categories, monitor sugars once in 2 to 4 hours in 2 hours. I would prefer 2 hours when the patient is on metformin, whereas on insulin every hour. The blood sugar should be always less than 120. IV insulin infusion with DNS is yes when the patient is on insulin, but no when metformin. And serum electrolytes, yes, is recommended, though we normally don't do it when the patient is on insulin. Now, how will you manage the patient in labor? How will you give insulin in labor? Well, if you have an infusion pump, yes, it is easy. You can see that you manage it with 0.5 units or to 1 unit per hour. But otherwise, you give 5 units, you add it in 500 cc of DNS and let it go at the rate of 100 to 125 cc per hour. And you titrate the rate depending upon the blood sugar. Very simple. Okay. Now, I've already told you about the intrapartum target, 70 to 120. Now, our patient had a vaginal delivery of a female baby weighing 3.4 kgs. In spite of a strict control, could be the obesity, and obesity must have sort of helped her in having this weight. In spite of everything, the baby had shoulder dystocia at birth. We know 50% of shoulder dystocia cannot be anticipated, and it also happens in smaller babies, but it was handled very efficiently by doing the usual maneuvers. Now, what is the next step, Dr. Sangeeta?
In case of shoulder dystocia, we should do proper documentation and debriefing all the steps, and we should also prepare for the litigation if there is some injury to the baby can occur also. So we should prepare the proper note like this. In this, we should enter the name of the patient, husband's name, what is the duration of the second stage, when the delivery of head occurred, whether it was spontaneous or instrumental, forceps applied or vacuum applied, and time of the delivery of the head, then initial traction was given on or not, and assistant name, and the arm under the symphysis, which arm was under the symphysis, right or left, and what
this is very, yes, Sangeeta. The arm under the symphysis is very important because there are reports where the arm under the symphysis, the anterior arm, was the right side, but the shoulder dystocia, but the Erb's palsy was in the left arm. So the doctor was not at fault at all. Okay, it would have happened even without anything else. So you have to mention that, and of course, who you called and in which order you did everything, and what was the condition of the baby at birth, and of course the mother, and then who was the doctor and who were all the people who called and the nurses there. So this is to prepare for litigation. Patient doesn't sue you, you're very lucky. But I know that there are so many cases in Bangalore itself where doctors have been sued for shoulder dystocia, and these things are still in court. Can shoulder dystocia be prevented by induction of labor? Now, this is something which we need to think about. Yes, in diabetic pregnancies, by inducing it when you know that there is macrosomia, again, a big question mark from scan, but even then you have to believe it. Can you reduce it? Can you reduce shoulder dystocia? Yes, in diabetic mothers or in GDMs, yes, by inducing a little earlier, you can to a certain extent decrease the incidence of shoulder dystocia, but evidence says that if there is a big baby in a non-diabetic mother, then you cannot prevent shoulder dystocia by induction of labor. There are many studies to prove it, though it sounds a little funny. Now, when you're doing a vaginal delivery of a patient with GDM or DM and you encounter shoulder dystocia, the dictum is try to get the head-body delivery interval less than 5 minutes, because hypoxic brain injury can be prevented if your delivery interval is less than 5 minutes. Normally, it's less than 1 minute, but the baby gives you that much of grace. So we should try to, so how do we go about that? By doing drills, so that if we encounter such a problem, you automatically do the maneuvers without trying to think, what should I do next? Of course, shoulder dystocia is unpredictable and unpreventable. Now, will you continue metformin insulin after delivery, Uma?
After delivery, the diabetic state of the mother reduces, her glycemia gets reduces. So women with GDM on metformin should stop it after delivery. And if they require oral hypoglycemic agents, metformin and glimepiride are allowed during breastfeeding. Women with GDM and insulin need their sugars to be checked after delivery. Insulin requirement will reduce by about 40%. During breastfeeding, the requirement of insulin can fall drastically, leading to hypoglycemia. So the dose of insulin needs to be adjusted accordingly.
Yes. So you have two factors which reduce the dose of insulin. One is that she has delivered, the baby is out, more than the baby, the placenta is out. And the second thing is she's breastfeeding, which is like one labor, one energy sort of the exercise. So that is the reason why we have to be very careful when we're giving insulin after delivery. Now, how will you manage an elective cesarean in a GDM patient on insulin? Well, nil by mouth, all of it is elective, so nil by mouth is natural. Most important, omit the morning dose of insulin. Check her blood sugar before you take her into the OT. Get her serum electrolytes done. Now, again, this is recommended, though we normally don't do it, but I think in the ideal circumstances, it would be better if we do it. Then again, post-operative blood sugars every 2 hours for the first 12 hours, 4th hourly later, till the patient starts oral feeds. And till she is on oral feeds, you have to give insulin, regular insulin, according to blood sugar sliding scale. Now, a word about, wait, not this. Yeah, when we come back to here. Does does the anesthetic mode make any difference in the sugars? Can anybody take it? Okay. See, if the patient, we don't give GA normally, but if for whatever reason the patient needs GA, then we need to be very careful because sugar spikes are seen when induction takes place, when you're inducing anesthesia, or when you're extubating. So when you're intubating and we're extubating, both times the sugar levels spike up. So you have to do your sugars every half an hour if your diabetic patient is undergoing any procedure under GA. That's very important. Okay. Then again, spinal, of course, makes no difference. Now, Dr. Aruna, how will you monitor the baby after delivery? Very important. The whole exercise of pregnancy is to have a healthy, happy baby. So how do you monitor the baby?
We have to monitor the blood sugar levels of the baby. 30 minutes, 1 hour, 2 hours, 4 hours, 8 hours, and again 12 hours afterward. At any time, if there are abnormal signs, we have to test for polycythemia, hyperbilirubinemia, hypocalcemia, and hypomagnesemia for babies with clinical signs. Put the baby for the breast as soon as possible.
Yes, it's very important. And the higher the blood sugar of the mother, the more the chances of hypoglycemia. So if the blood sugar is less than 40 milligrams, or if it is persistently less than 36, then in that case, usually the nurse is the one who checks the sugars. Then in that case, it's very important to inform the pediatrician so that 10% glucose can be given. It has happened earlier that in one of my patients earlier that baby had very resistant hypoglycemia when we had to give glucagon also to correct it. So just keep in mind, and when we say abnormal clinical signs, they can be jitteriness, convulsions, and then the baby is not able to, the baby doesn't take feeds. So we have to be very careful and tell them that all these are signs, red flags, which they should alert us about. What issues will you address in the postnatal visit, Dr. Reena?
Yes, ma'am. I will check her weight, whether it is increased, and advise her for weight reduction by
All
proper
these are
diet.
for advice now, basically for advice, yes.
Yes, by proper diet. That is a high fiber, low fat diet. Along with that, low glycemic carbohydrate with low glycemic index she can take.
Yes.
And regular exercise. And she can, and contraception also. She can use almost all contraceptives, available contraceptives.
We'll come to it.
Okay.
And she should continue breastfeeding for as long as possible. Okay.
As long as possible. And again, and I would like to check her glycemic status also.
Yes, very good. Now, when will you ask her to come for follow-up, Dr. Sangeeta?
After 4 weeks to say 6 weeks, we will call her. 6 weeks to 6 months. Up to 6 months, we will call her, and yearly thereafter. And when she will come, she comes at 6 weeks, we will go for the fasting plasma glucose or OGTT. If it is after 75 grams, if it is more than 199, then she is a case of diabetes mellitus. So we should refer her to a diabetologist or physician for further management. If it comes between 140 to 199, then she is a case of impaired fasting glucose. So we will refer her for the management with diet therapy, weight loss, exercise, metformin, or nutritional therapy, and she should come for yearly assessment also. And
Yes,
if
now,
GS
yeah.
is less than 100 gram and 2-hour glucose is less than 40, then she is a normal patient. Still, she should come for the yearly assessment, glycemic assessment, and
Perfect.
she should,
See, that's very important.
develop weight loss and nutritional therapy.
So whenever she comes, so she has to come every year. And 3
Yes.
years if she has a normal blood sugars. OGTT plus a HbA1c, both have to be done. I haven't mentioned HbA1c here. So if it is normal for 3 consecutive years, then she can come once in 3 years again, not every year. So that is important. Now we're talking only about diabetes here, but we also have to advise her about what? Cardiovascular disease, because these people are very prone to cardiovascular disease. So we have to impress upon them every time she comes to us that she should not put on weight. She should follow her diet as you all have advised and continue to do exercise so that, with lifestyle modifications, she can at least put off the CVD and type 2 diabetes for a longer time. Now, what are the choices for contraception, Dr. Uma?
We can
She's
advise
a well-controlled diet. She was having GDM, now she doesn't have. So what are the choices?
We can advise them barrier methods. All hormonal methods
A
are
barrier has a failure rate of 10 to 14%.
okay.
Would you like to do that?
Okay, we'll go for all hormonal methods for women with GDM and diabetes mellitus without vascular disease. Depo-provera and contraceptive pills, oral contraceptive pills are avoided in women with vascular disease.
Yeah, yes, because
The
they are
LNG,
category 3 and 4.
the LNG, IUCD, and copper IUDs and Implanon have low risk of thromboembolic events than contraceptive pills.
So the bottom line is she can have an IUCD, LNG or copper, both are okay, or Implanon, or she can go for COCs.
Progesterone only.
Yeah, low dose COCs or even progesterone. Now, Depo-provera has been found to increase the chances of developing type 2 DM in a patient who had GDM. There's one study which says that. There's another study which says 17-hydroxyprogesterone also during pregnancy can increase the chances of GDM. Anyway, we need further studies to prove these. So in conclusion, no single period in human development provides a greater potential than pregnancy for long-range payoff by a relatively short-range period of enlightened metabolic manipulation. And this was by Norbert Frankel, and he was referring to fetal origin of adult disease. Very important. So we as obstetricians should not lose this golden opportunity. Why? Because quite a lot of our people don't come back to us once they finish their pregnancy. You see them sometimes if they have problems during menopause. So for such a long time, they're without care and without supervision. So whenever we have the chance to have them under us, we should see that we do a good job so that we see that the sugars are under control, we detect their diabetes or their GDMs and provide them ample advice about how they should live their lives in the future so that we can break this intergenerational propagation of diabetes. I didn't thank in the beginning. I thank Bharti and Vidya and of course Rachana for involving me in this, and I thank my panelists for doing an excellent job. Thank you so much.
Thank you, ma'am. Thank you.
Thank you, ma'am, for such an excellent panel discussion, ma'am. You have covered every point, ma'am, and it is the latest information what you've given us. Thank you so much, Jyoti.
Thank you, Rachana. Thank you so
and
much.
all the panelists for being here. It's
Yes,
got
very
really late.
sweet.
It got extended. I'm so sorry for that. Yeah.
It's okay. It happened.
Well prepared panel questions. Thank you so much,
Yeah,
ma'am.
they were very good. They were very good.
Jyotika, that was an excellent coverage of the entire scenario of management, prenatal, intranatal, and postnatal, and also the consequences of GDM. And also, we thank all our esteemed panelists, Dr. Uma and Dr. Aruna. Dr. Arpita has not been there, and then we have Dr. Rajpal was not able to attend. So we thank you all for participating in this excellent webinar. And I think we all need to always screen this GDM with the glucose challenge test and manage them. Because even today we are seeing many practitioners who have not taken up this practice of universal screening for GDM. I think all of us have to change the way we practice wherever we are, irrespective of the scenario where we are working, because this is a very, very simple test. And if we have to control the fetal programming, we have to do this screening for GDM in each and every woman, irrespective of her age or her ethnic background. This is a sincere appeal to all of our practitioners. Please do this screening for GDM.
All the best for Vidya and Bharati.
Yes, thank you, madam.
Thank you. Thank you very much.
All our support is there with you all.
Thank you.
Yeah. Thank you very much. And it was very extensive discussion, I must say. And you covered every minute this one discussion and minute management of GDM. As always, Jyotika. Thank you very much.
That's your love speaking.
No. The panelists were also very excellent.
They were very
and really it is take-home messages were also.
Dr. Sangeeta, Dr. Uma, Dr.
So many messages are there in the chat box, and that shows your popularity.
Bharti's talk also was very good.
Yes. Always she speaks very nice.
And
madam, thank you.
Shivanand was so much. Yes, Bharti?
Yes, Jyotika?
No, I said Dr. Shivanand's talk was so extensive.
Yes.
He went through all the 9 months all over again.
The topic, see, as you said, the pregnant lady does not like to go to the dermatologist. And so these initial certain problems, we obstetricians can give them the management with the guidance of the dermatologist.
He spoke very well and at length about each and everything.
And the pictures and everything, no, he demonstrated.
Yeah.
Though were very eye opener for us also.
Yes.
For diagnosis and all. Very nice.
At least you know whom you can send to now.
Yes.
Thank
you.
Thank you, Dr. Rachna and Shobha. I think you can go ahead with the formal vote of
Shobha,
thanks.
Yes,
Shobha is here.
Yeah, I'm here. Rachna, can you hear me?
Yeah, you can. Go ahead, Shobha. Please thank the audience.
So we have come to the end of a very wonderful and very informative webinar today. So at the outset, I would like to thank the patron of KSOGA, Dr. M.G. Hiremat sir, and also Dr. Nagraj sir. And I would like to thank our dynamic president, Dr. Bharti Rajshekar madam, and our vibrant past president, Dr. Vidya Tobbi madam, for starting this program and making us aware of so many things, newer developments. I'd also like to thank Dr. Durgadas sir, who is the president-elect of KSOGA, for supporting the program, and our ever cheerful Dr. Rajashri Paladi madam, the secretary, and Suman Gadi madam, the treasurer, for being there and supporting the program. I would like to thank our chief guest, Alpa Kriplani madam, who is a wonderful and very amazing academician, and thank her for her blessing for this program. I'd also like to thank the guest of honors, Dr. Janameja Mahapatra sir, and Dr. Suchitra Pandit, for being there and blessing the occasion. And I would also like to thank the speaker, Dr. Shivanand sir, who did a wonderful job on enlightening us about skin disorders in pregnancy and gynecology. I'd like to thank the chairperson, Dr. Jyoti Banglawala madam, for both the talks. I'd like to thank Dr. Jyotika Desai madam, who did a wonderful job on panel on GDM. It was a really eye-opener webinar and gave us a lot of practical points to practice. And also thank the chairpersons of the session, Dr. Arpita madam and Dr. Asha Bakshi madam. And I would also like to thank the panelists who stayed till the end, which was a very extended session, Dr. Aruna madam, Dr. Reena madam, Dr. Sangeeta gar, Dr. Uma, and Dr. Brijbala Tiwari madam. And also like to thank the delegates who attended, and I'd like to thank Dr. Rachna for being the convener of the program. Thank you, everybody.
Thank you, Shobha. Thank you so much.
After 15 days.
Yeah, our next webinar will be in another fortnight on a Wednesday.
Okay.
Thank you,
Okay.
madam. Thank you all. And have a good night. Bye-bye.